reported 51 cases from different areas, from the muscles, from the brain, from eyes, from nose. But intestine were not detected.
Because my husband is a pediatric surgeon, so I got some specimens luckily. And I have seen this was the fourth case I saw.
And it was published, our study was published in the IAPM journal, 51 cases.
If
Thank you very much,
there,
madam.
if there is a necrosis, if there is a low immunity, the mucormycosis are opportunistic infection, and you are likely to get all these things. Thank
Because
you.
even in the literature it is given, neutrophilic infiltration is there, necrosis is there, it is mucor. Thank you so much, madam. So much.
Thank you so much, ma'am. Now I would like to Dr. Vyas sir and Dr. Manju Raghav ma'am to please come forward and present the memento to Nirupama ma'am. थैंक यू वेरी मच निरुपमा मैम. व्यास सर आप लोगों को दोनों को भी एक और सेशन शेयर करना है. यू हैव टू बी हियर ओनली. नाउ आई वुड लाइक टू इनवाइट डॉक्टर पूनम अलांस मैम टू प्लीज कम फॉरवर्ड ऑन द स्टेज. Ma'am is from AIMS Jodhpur and presently she is the head of the Department of Pathology.
So much, that's just administration. Yeah. A very good afternoon and namaste to everybody who stayed till now to listen to this session, and thank you so much to the organizers for inviting me. Thank you, and without much ado I would like to go on to my presentation. I have very basic cases. If you're expecting something out of the ordinary, it might not be that, but thank you. So I have called this session a medley of HNE with a little brown in the era of NGS. So nothing very hi-fi, just a little bit of brown, and I would like the audience to be interactive. So, and maybe not from AIMS if possible, because they might have seen these cases. So the disclaimer is that all these images are from our own patient resources, and 2 images have been borrowed from Wikipedia for the purpose of illustration, and this is under the Creative Commons license. So this is the list of cases. I'm not sure if I'll be able to cover all, but this is the list of the cases. So I have 5 cases with me. So the first case, it's a busy slide, so this is just the presenting features. So the first case was a pretty recent, am I audible to everybody? Okay. So the first case is a 65-year-old male who had difficulty in walking and giddiness for 15 days. So again, that same cat is around. And this patient had headache and truncal ataxia. When he presented to AIMS Jodhpur, his Glasgow coma score was pretty low. So he's a known opium addict and he has no other comorbidities. He arrived with a brain imaging done from outside the institute, which suggested a cerebellar space occupying lesion. I think maybe it's going to. So the surgical team planned for a CSF diversion ventriculostomy, and with that, they thought there would be improvement, but the patient dipped further. The verbal commands went to nil. A repeat NCCT head was done. I like this cat. So in the immediate post-op period, the patient's condition worsened. And unfortunately for us, he passed on the next very day. But in that period, they could do a gross total excision of the tumor, which was sent to us. They called it a soft, suckable, moderately vascular tumor, which was not bulging on the surface. So as we can see, I'll use the pointer here. I'll use the cursor here. We all can see the cerebellum. Yeah, and we can see. So, any resident, what is this? Anybody, I mean. What do you think the image is? These are H&E stained images. So, any thoughts on the lower right-hand corner? So, otherwise, I'll keep on talking. So, as we can see, these are some necrotic, hemorrhagic appearing areas. No, pretty dirty looking, not something very nice. So, again, as Dr. Nirupama and many others have showed, so we have these giant cells. So, more giant cells, but along with the giant cells, what else can we see? We can see a lot of perivascular cuffing, right? So, we have a lot of mixed, in the picture on the top, we can see plasma cells. I'm not sure whether they are apparent, but to me they are. So we have a lot of multinucleated giant cells, and as we know, when we see giant cells, we have to see uske andar kuch dikh raha hai ki nahi, right? So that is what is being taught to us from the beginning. So please look at the giant cells. Any idea what this could be? It's a monkey. It's a monkey for everybody. It's a special sort of monkey. No. Okay, so this is the image I borrowed from Wikipedia. This is the source of the lesion that I'm going to show to you. So can you see what Dr. Nirupama showed in the interesting, can you see the thing right in the center here? Anybody? So that's a trophozoite. That's a trophozoite for us with a large, it's a large size cell with a central, with vesicular nucleus and a prominent nucleolus. And you can see a mixed inflammatory picture. Look at the one, you can see so many trophozoites once you start seeing. And the speciality of these trophozoites is they just start to eat the vessels and cause a hemorrhagic necrotic vasculitis. So just look at this. Can you see the vessel on the top? And look at the way these trophozoites are just going around the vessel and they're eating it too. So this is, and look at this here. So many trophozoites, you know, the slide was studded. In fact, when we told the clinician that it is not a tumor, they wouldn't believe us. But by the time the patient had already passed on. So just look at these structures. Can you see all these fusiform or these, big looking structures, very large cell, 40 to 50 microns. You can easily pick them up even on an H&E. So the Masson's does not come up well, but you can see the vessel in the center and all the trophozoites around it. So one thing about amoebic trophozoites in the brain is that for the variety I am talking about, they will not stain very well with either PS or with Masson's. Thank you. I'm okay. So what the final diagnosis suggested by us was it's a granulomatous amoebic encephalitis, most likely Balamutia, right? So, and we sent ribbons of this blocked paraffin material to PGI Chandigarh, the Department of Medical Parasitology, where Dr. Abhishek very kindly did it for us, and he confirmed that on nested PCR that it was positive for Balamutia. Just a little thing about, in this region, why it is important. This is possibly my colleague Dr. Divya had a similar case this year only, and we had another case. Hers was a young male who presented with classic skin lesions, and our patient came pretty late in the day with about a month-old history. And so we need to know about entamoeba yahan pe, because it's an upcoming problem, and around 200 odd cases have been recorded in the world. So these are free-living amoebae. I'll not go into, there are several genus. So we have Naegleria, we have Acanthamoeba, we have Balamutia, and we have another variant called Sapinia. So almost all of them, they come to us pretty late. They have a poor prognosis. Naegleria, has a fulminant course. The others don't, but the prognosis is poor. So I'll not go into Naegleria. I'll just tell you what we call this case. We called it granulomatous amoebic encephalitis. And it is caused by either Acanthamoeba. Many contact lens users, and many of us might be doing neti with that neti pot in the morning for clearing the sinuses. Even that has been found to contain free-living amoebae. So just a word of caution here. So what we have to remember is that when we talk about Acanthamoeba and Balamutia, these tend to primarily cause disease in immunosuppressed or debilitated patients, which ours was not except for the opium addiction. And Naegleria usually the patient will have an exposure to swimming in freshwater bodies. And as Purohit sir asked Borges ma'am, कि इतने लोग जैसे नदी में घूमते हैं लेकिन होता एक ही को है, बहुत कम होता है. What is the reason? So even they are looking into it, So I showed you this monkey, and this is nothing but, so we have an Indian called Govinda Visveshwara. He was the person, in the honor of his late mentor, Dr. William Balamuth, he called it Balamuthia. And in the, he named after this monkey, it was a pregnant monkey, and it was called a mandrill monkey. So this is nothing but a mandrill monkey, which is called Mandrillus sphinx. Iske andar, she was a pregnant lady when she died, and they autopsied the brain. They saw these organisms which were not matching with any other free living amoeba. So that is how they called it Balamuthia mandrillaris. Just a little bit about history. So that was the first case. This is something which I have picked up from one of my slides of the pap smears. Anybody? In the RAJPATHCON 2023, somebody presented a similar case from a patient who went to Africa. It looks like, something weird. So what could this be? Anybody? Believe me, it's not fancy. It was right there on the slide. So this is a pap stain slide of a cervical smear, and this is nothing but a plant trichome. We have to be aware of this because, in these days with all sort of global movement, we do get patients with my friend Dr. Lisa from Padar. She presented a case where a patient visited Africa and came back with a cystic swelling, and they saw similar structures. So I just want to tell you that this is nothing but a plant trichome, right? Trichome. And this is the image I borrowed from Wikipedia, the one lower down. So that's case one. Any questions on this? So Balamuthia mandrillaris. So I'll come to the second case. This was a 15-year-old young boy, a school-going child, who initially had a small swelling noticed incidentally for about 2 months on the left side of the neck. Yeah, initially about 3 by 3 centimeter, progressed over 2 months to attain a bigger size, 11 by 4. So there was no significant history, nothing except for this swelling. And on examination, as we see, when there is a neck swelling, you look for deglutition, you look whether it was pulsatile, there was nothing. So we do direct FNA. We did a direct FNA. A 12 milliliter of turbid yellowish fluid was aspirated. Any thoughts so far? Turbid yellowish fluid, young boy, 15-year-old, left side of the neck. Any thoughts? Any cystic swelling? You can name any cystic swelling in the neck. Excellent. Very nice. So sir has said a branchial cyst, which is what we thought too. Very right. Thank you, sir. So just look at this. So a beautiful H&E stain to show you the cholesterol plate crystals, right? And some inflammatory cells in the background. The Giemsa stain smear showed you eosinophils, which I'm not sure are very apparent, but it showed a lot of inflammatory cells and a fluidy background. So with this, we also gave a diagnosis of a benign cystic lesion, possibly branchial cyst. So obviously it is not branchial cyst if I'm standing here and showing it to you. So this is the clinical image. I want to thank my colleague Dr. Darwin for sharing this. So just look at this huge thing. It was for the first time I'd seen something with a tail, with a tail-like appendage. That's a huge cyst on the top with a tail-like appendage extending right down into the mediastinum. And when we cut it open, that is what we saw, a very darkish looking image, but that is what it's unilocular. It's unilocular, it has got a variably thick wall, some whitish looking areas, you can see them at the periphery. So with that, when we went on to the microscopy, any thoughts now? Still branchial cyst, maybe, or another cystic lesion of the neck. So as rightly said, we will discuss cystic lesions of the neck here. Thyroglossal cyst, though it wasn't in the center, it was lateral and it was not moving with deglutition. Branchial cyst, very right. But it's superficial, lateral, rarely extending to the clavicle. This was one going right to the mediastinum. Lymphangioma, it can be cystic, but these are brilliantly translucent. So bronchogenic cysts, epidermoid cysts, cystic lymph nodes, and rarely thymic cysts. So when we took the microscopy, this is what we found. As you can see on the top, I wonder how this will work. Yeah, okay. So, yeah, so is it, I'm not sure it's working on the screen, but that's okay. At the top of the image, you can see the lining. So that's the lining epithelium saying it's a true cyst. And we can see all these dilated blood vessels, a lot of reactive follicles, yeah, with germinal centers. That was nothing but, maybe FNA induced or maybe chronic long-term hemorrhage. So a lot of cholesterol crystals with foreign body multinucleated, yeah, foreign body granuloma and cholesterol deposition. So here come the tricky part again, a lot of proliferated vessels. Yes, so what do we have here? What are these structures which I pointed out with the yellow arrow? Maybe it's not very apparent, the picture quality might be a bit tricky. These are nothing but Hassel's corpuscles, right? So we have a lot of Hassel's corpuscles. Maybe in the center you can appreciate it better. So we had a lot of Hassel's corpuscles in this image. It's there on the upper right hand too. So with that we went for a diagnosis of a cervical thymic cyst. Yeah, the age is correct. And the lesion was extending right to the mediastinum. Also associated with this was a parathyroid gland, because as we know, the parathyroids and the thymic, they get their origin from a common thing. So these tend to be diagnosed clinically as branchial cysts, right? The origin can be either from an ectopic remnant of the thymus when it undergoes secondary degenerative changes, or origin from cystic degeneration of the persistent thymopharyngeal duct as it moves down. So I've already told you this, but we had parathyroid tissue. I have not put it in the image, but both thymus and parathyroid glands are derived from the third and the fourth pharyngeal pouches. That is how they move together. These are mostly elongated and range in size from 1 to 26 centimeter. Ours was 11 centimeter. They occur in region between the angle of the jaw to the sternum. Anybody, what is this? This, we had a specimen of urine recently, and I wanted to put the video, but there was a lot of noise and excitement in the background, so I just cropped that video and got this. Anybody? This, I think all of us will get to see. This is from our own department. We got a urine specimen, and that lady was, I think, admitted in the ICU possibly. And the urine had many of these creatures. Do we agree it looks like an organism? Actually, I put an iodine stain so that it could highlight as yellow. Otherwise, we see dikh raha tha. So, no, it was in urine, but it's a contaminant. So that is why I want to show it to you, because all of us might get to see it one time or the other. There's a creature called a water bear. It's one of the oldest creatures known to mankind. It is tardigrada. TARDIGRADE, tardigrada, or a water bear. So tardigrada ki kya khasiyat hai? It can survive extremes of temperature, hot springs, Antarctica, desiccation. 10 saal usko aise pani nahi milta. The only place where tardigrades do not survive is the human body. Right? So this is a contaminant which most of us will see from the water which we are getting. This is nothing but a water bear or a tardigrade. And because we put that, it was looking very cute moving around. It had these, it highlighted its red eyes, the iodine stain. So this is nothing but a tardigrada or a water bear. What is this contaminant? It's a water bear. So it's an 8-legged micro animal. It's also called the moss piglet. Ye pig jaisi shakal hai aur bear jaisa dikhta hai. So this is, I just wanted to show it essay, to break these. So case 3, so this case is from a 25-year-old lady. She had a swelling in the oral cavity which was present for about 10 years. 25-year-old lady, swelling in the oral cavity for about 10 years, initially small. She came now because it was growing larger and causing difficulty in swallowing. Otherwise she had no problem. A clinical diagnosis of a hemangioma was made. So this swelling was excised by the ENT department and sent for histopathological evaluation. This is about a 5-year-old case. So this is what we saw on gross. So can anybody describe? Does it look like classical prototypical hemangioma to any one of us? Yeah, maybe if it has bled a lot, chronic bleed. Sorry? Smoke. No, it's a 25-year-old lady. I don't think she's smoking, but maybe she is. I wouldn't know. That's my judgment talking. But so, we've seen it's almost a circumscribed mass, but there are yellow areas, there are very ugly looking blackish brown areas, white surface. So it's something with a mixed picture. Having shown that, we will come to. So this is what the microscopy showed. Can any one of you describe a few features? It's just a mutual exchange. कुछ भी बोल सकते हैं. ये क्या? ये structure तो सभी ने देखा है. Excellent. So that's a Samoma body. Very, very nice. And you can see some fat on the top. We can all see blood vessels, and we can see some blood vessels, fat. We can see some calcification here. And what else can we see which is so brown? Excellent. So somebody said hemosiderin, somebody said melanin. I agree with both, and I'll show it to you. Very nice. So if you see, we have a tumor. We have a lesion which has melanin, which has maybe got hemosiderin, it has got blood vessels, it has got some fibroadipocytes, and it has got this vaguely fascicular lesion, spindle cells moving all over the place. Anybody? We see this structure in the spleen and chronic venous congestion. Excellent. So that's a Gamna-Gandhi body. Gamna-Gandhi body can be seen anywhere where there is chronic hemorrhage, some deposit of calcification, fibrosis. So you can see fibrosis, you can see, those calcific strips, and we can see some hemosiderin. So this lesion had a lot of bleed, so they were not far off when they said it's a hemangioma, some inflammatory cell, some fibrin. Any thoughts so far? You have a lesion which is spindled, not very atypical looking, with hemosiderin, with melanin, hemorrhage, some fat in the oral cavity. Any guesses? Any guesses? कुछ बोलने से तो कुछ भी बोल सकते हैं. Sorry? नहीं, even we really broke our heads over it. So as somebody very rightly said, so we've done a pearl stain to demonstrate the hemosiderin. So we have hemosiderin on the right hand side, and what is not staining is the melanin. Right? So any thoughts so far? A circumscribed lesion, long standing, 10 years. Oh, excellent. Who said that? Very nice. So, sir is on the right track. Thank you. So, just look at this. So, I said I'll throw a bit of brown inside. So, we did IHC for S100 protein, which is very beautifully positive. IHC for HMB45 because there was a lot of melanin in the lesion, very nicely positive. I told you it's a 5-year-old case. We were not doing great, too many antibodies that time, but we did a KI67 to show whether it had a low proliferative index. We did a CD34 that was negative. We did a EMA that was negative. We got calcification. We did an SMA. We did a CD117, all negative. Any thoughts so far? So if it's a neurofibroma, we'll usually get a CD34 positive. Or if we think if it's a pigmented DFSP, it again would be a CD34 positive. It will not have fat. It usually does not have Samoma bodies. Any thoughts so far? Sorry? Granular cell tumor. Okay. Anything else? So I said it was negative for a lot of things. But yeah, very right. What else? Why not malignant melanoma? Somebody said, okay. So I didn't show you any prominent inclusion like nucleoli. I showed you Samoma bodies. But yeah, and I said the KI index. The KI index is very low. It's not even, the labeling index was not even 1%. Okay, so with that, there is an entity, as we know, don't go too far, So this is just an overview of the same thing again. So, yeah, so I've written something. So a diagnosis of a Samomatous, it was called a Samomatous malignant or a Samomatous melanotic schwannoma, but now they've changed the term. They call it malignant melanotic nerve sheath tumor. But they are not sure about the malignant potential even now, or the metastatic potential. And we should remember that we called the patient back to the hospital. She's from beyond Nagaur. So she came, she was examined for other endocrinopathies, skin lesions. She did have a few freckles and macules, but nothing significant. So as we know, 50% of these cases are associated with Carney's syndrome. But she, as of maybe 2 years back, she had no such features.
I agree with this one, the second one. 50% of these cases are associated with Carney's syndrome. But she, as of maybe 2 years back, she had no such features. 50% of these cases are associated with Carney's syndrome. But she, as of maybe 2 years back, she had no such features.
Yeah. Yeah. Thank you. Yeah. Thank you. But actually, sir, as we all know, there is so much of updation, so many changes going on. वो इधर से नाम बदलते रहते हैं for whatever purpose. So they've chosen to call it. I mean, this term is acceptable, but they've chosen to call it, as I said, malignant melanotic nerve sheath tumor. But even they are not very clear about the metastatic potential or how it will behave long term. So it's a rare tumor which occurs in the posterior spinal roots. I think I'll skip this because it's got a syndromic association. That is why possibly the need to look for. In the newer 2023, they've called it a malignant melanotic nerve sheath tumor, and they're still not very clear as to how it will behave. Yeah. Thank you. So, anybody, what is this? Again, another googly thrown in. So, this was a case of oral squamous cell carcinoma, and this patient was really far gone, and he had ulceration of the skin. So, can you see this weird looking structure? This was the first case I did as an intern. मेरे surgery के resident ने बोला था तुम ये करना आके. So this patient had maggots on his leg and he made me scrape that. So this is a maggot. This is how a maggot looks on microscopy. Can you see those weird looking appendages at the periphery? So this patient, he ulceration of the lesion with maggots inside. So do I have time? Oh, okay. Otherwise you can cut me short. I'm not. So this case is for the 25-year-old lady. This I think most of us will tell. Swelling in the right medial aspect of the thigh for 3 months. It was painless swelling, increasing in size, and FNA was done. So the FNA shows mainly a hemorrhagic background, but oops, sorry. Yeah. So I think I'll keep this aside. So this is. Anybody who wants to describe these cells? Large cells, yeah. Large cells, abundant, foamy, vacuolated cytoplasm with an eccentric, large round nucleus. Maybe prominent nucleoli, some bare nuclei in the background. Any thoughts so far? 25-year-old female thigh swelling. I'm sure you'll hit it right on. So again, a large nucleoli on the top in the bare cells. Again, similar cells, and that's the cell block we made. So cell block showing very pink looking cells which are large. Sorry. Pink looking large cells in a hemorrhagic background. Excuse me. Now you can tell what is this. I've made a star for you to see. There's a yellow star which will show you. And that's a PA stain slide. Periodic acid shift. 25-year-old lady, thigh swelling. And what is this pattern? Very nested looking pattern with some capillaries. What are these? Can you see those deep pink color, elongated structures? If I tell you, can you see that star? So there are these sinusoidal like capillaries separating these nests of large cells. So what is it? So the differential diagnosis could be a paraganglioma, granular cell tumor, adrenocortical, kuch bhi, rhabdomyosarcoma, clear cell sarcoma, perivascular, PCOMA. But see, keeping all that in mind, we did these IHC. The first IHC is for Desmond. Desmond is dead. Then we did what? Anybody, can you guess? I've written, no. Can anybody guess this IHC? We have some fat which is staining positive for that IHC. So, ma'am, I think Ajay ma'am is saying, so this is S100 protein. So, S100 dead negative. What is that IHC? Which is showing nice, beautiful nuclear positivity. It's TFE. Right, so I'll just show you, we have an IHC for TFE because our diagnosis was alveolar soft part sarcoma. Right, so it's a rare tumor of the deep soft tissue, comprising about only 0.5 to 1% of all soft tissue tumors, usually young women. Metastasis, the patient might not give you history, might have a lesion in the brain or the mediastinum, lungs, many years down the line. So what I was showing you were those rod-shaped crystalloids which come beautiful. Usually you might not get, but we got beautiful ones on the PS stain. So that was just to show you that I've described the picture large polygonal set. So this is just to tell you that there was a TFE3 gene which forms a fusion gene partner, and that is what was picking up on the nuclear positivity. So case 5, this is the last case for the day, and thank you so much for listening. So again, a 53-year-old lady with a swelling in the left submandibular region for 3 months. And she also had complaint of earache since 15 days. On examination, there was a firm, non-tender swelling in the angle of the jaw with multiple foci of calcification on ultrasound. So this is, we do direct and guided FNA. These days it's shifting more to guided, unfortunately. Can anybody describe these clusters? Do they look good to us? Do they look very benign and banal? No, they don't look good. Though they are large, they are ugly looking. Look at the nuclei. Even at this, we can see the nucleoli, we can see mitoses, which I've pointed out with the arrow. So again, very cellular clusters, very cellular. And even in, FNA, we said we picked up calcification. We picked up prominent nucleoli, moderate to abundant amounts of cytoplasm. Any thoughts so far? A high-grade lesion, submandibular gland. Prominent nucleoli, very cohesive. No, I've not shown you any other cells. No squamous cells, no background, no bare nuclei, no acinar, nothing. Very cohesive. So I'll come to. So what is the differential diagnosis when you come to a salivary gland? It might be a primary. It could be primary, it could be metastatic. So primary salivary gland neoplasm with high-grade transformation. You could have a high-grade MEC, epithelial myoepithelial carcinoma, adenoid cystic, didn't look like that, adenosquamous or infraductal. So again, this is a list, it's all available. I'll not go into this. This was a cell block. I was waiting to show this slide. So beautiful cell block. I think most of you would agree. And you can see nice pink cytoplasm. Abundant to moderate amounts of, eosinophilic to oncocytoid, if I may, cytoplasm. Large nuclei with a prominent nucleoli. Background is hemorrhagic. What stain what IHC have we done? So it's membranous IHC. Any carcinoma in the salivary gland which resembles something in the breast, and you use the same IHC in both places? Very right. Some people are whispering. So this is a HER2/neu IHC. So it's a beautiful HER2/neu positive. We did a dog 1 that was negative. We did a 117 that was negative. So any thoughts so far? Salivary duct carcinoma. So this is when we got the excision specimen. This is exactly what it showed. And please tell, this is not oncocytic. Why? Because we know salivary ductal carcinomas do tend to have abundant amounts of bright eosinophilic cytoplasm. Just look at the nucleoli, they're giving you that look. Sab aapko ghur rahe hain. So they are large nucleoli giving you that look. And as I said, we picked up the calcification on even FNA, we wrote it in our finding. And by that time we didn't have an ultrasound, let me tell you that. We also work like that. So we can see the calcification in the image on the right. And what else do we see in this? So we see very crazy looking cells. So again the HER2, HER2/neu. What is this? Anybody? Once again. What is the structure and what do you think might be the structure which has taken up so much of brown dab in this? I told you it was going to the ear. So what am I trying to tell you? There could be some. I'll show that in an image. So this was S100 protein, which was negative in the tumor cells and it was positive in the nerve funicle. So this is an androgen receptor. So beautiful androgen receptor positivity borrowed from the WHO Blue Book. So that's a cytokeratin 7. If you can see all the epithelium that is staining with the cytokeratin 7, and we can see the nerve funicle here at the bottom right, the big nerve. So we had a lot of perineural invasion in this case, right? So the final impression given was a salivary duct carcinoma. So as I've already told you, these are invasive tumor cells with ample or abundant amounts of eosinophilic cytoplasm, forming cords, nests, and cribriform glands. And nuclear cytology you've seen, it is high grade with nuclear pleomorphism. And there are several variants. I'll not go much into the theory, makes no sense. So IHC, androgen receptor positive, GATA positive, CK7 positive, HER2/3 may come positive in 10 to 35% of cases. Prognosis is usually poor, and one of the factors is a perineural invasion, which we had a lot of. So these are my references for these cases. And I would like to acknowledge all the patients. Unfortunately for us, learning is at the expense of all the patients who come to us in miserable states. My colleagues who've, either they have gotten the histopath or they've gotten the cyto, the senior and junior residents and the technical staff. And this is the final slide. I would like to invite all of you to please register for CytoCon 2024. It is at AIIMS Jodhpur. Next year, 16th to 19th November, the dates are already blocked. We will have international and national speakers both. This is our auditorium. And so this is it. And thank you very much once again for calling me. Thank you.
Thank you so much, ma'am. Enlightening talk, packed with valuable insights.
Thank
Now
you
I
so
would
much, ma'am,
request-
for your nice presentations. And these rare cases. Generally in salivary gland duct carcinoma we see the comedo patterns, which we'll see in the breast most commonly because they are advanced.
Because this is just a snapshot, I can't show the whole case, so we just pick up something.
Yeah.
Thank you.
Thank you.
Hello. Madam, I had a question actually, or rather I want to add. The first case which you told about the free living OMB, people have got very little, especially the pathologist has got very little knowledge about the free living OMB. It is actually Naegleria fowleri and the Hartmann-Alla. I had a very interesting case in Nigeria. The patient came with meningitis, and we isolated the Hartmann-Alla and Naegleria fowleri in the CSF, and we thoroughly and deeply inquired about the case, and we came to know that that patient was traveling on the highway, and he was a Muslim patient, so he stayed for prayer, and it took the snake. So it actually penetrated the cribriform plate. It went to the brain, and the CSF was infected with the Naegleria fowleri. We did the culture on the non-nutrient agar, and it grown very well.
Beautifully, yeah.
We have published it in American Journal of Clinical Parasitic.
Thank you so much. Thank you. As sir has very rightly said, that's one point which we all need to know. CSF, you will usually pick up Naegleria, but not Acanthamoeba or Balamuthia. Yeah. And what is the other way to see those organisms? You can even don't need
float actually.
Absolutely.
Very
so you see them, moving with their pseudopodia or whatever they are called.
Actually, they are contaminant.
Yes.
Most of the time it was the water. We use the dirty water.
You can even warm the water.
If urine specimen, this tube are not washed properly, you will see this amoeba.
Absolutely. Thank you.
They are contaminant actually. They are contaminant basically.
I would request
We
Dr.
have to
Vyas sir
look
and
for
Manju ma'am to
non-nutrient
please
agar.
felicitate.
Put them on non-nutrient agar
Poonam ma'am.
culture. That will be used.
Thank you. Thank you so much. Thank you, sir.
Thank you so much, ma'am. Thank you so much. I would request Dr. Rajni Joshi ma'am to please come on the stage to felicitate our chairpersons.
My goodness, my classmate is hitting me.
There is an important announcement. The delegates who are having poster or paper presentations, please submit their submissions. the candidates who are participating in posters and oral paper presentations. Yeah. Kindly give their presentations. Now we will have a next session.
Next in the row. Now we would like to invite our next speaker, Dr. D.R. Mathur sir, ex-senior professor and head of Department of Pathology, Dr. S.N. Medical College, Jodhpur. He has been worked in various medical colleges of Rajasthan, published around 150 research papers in various national and international journals. Please, Dr. D.R. Mathur sir. Session will be chaired by Dr. S.N. Chawla sir and Dr. Neena Kasniwal ma'am, who is Senior Professor Pathology in JLN Ajmer.
Before I start with the mycetoma, it is with the advice of my friends, Dr. Yogiraj Joshi, who has told me that we must speak on mycetoma. And of course, Dr. SP knows very well that a lot of work has been done at Bikaner. Initial work was done by Bikaner by Professor K.R. Joshi and Dr. Harban Singh. Later on, it came to Jodhpur, and Dr. J.J. Sharma also did a lot of work, along with Professor K.R. Joshi sir. Truly speaking, I am not hesitant in telling the fact that I have learned the art of typing the mycetoma cases from Professor K.R. Joshi only. Why this is important actually? There is nothing, it is specifically research or anything in this. But there are 2-3 things which are important about the mycetoma. One is people confuse mycetoma with actinomycosis, number one. And number two is that the treatment modalities vary substantial. So with that in mind, actually, the characteristics of mycetoma is basically exogenous infection. I remember very well, I will give you a good example, one very senior professor who had a good knowledge of the subject, I don't say it. Then a pelvic mass, he reported mycetoma. I wonder, it is the endogenous. It is endogenous. It cannot be, because it has to be exogenous. It has to be from exogenous infection, usually characterized by swelling, multiple discharging sinus, and granules. No, again, one more thing. When there is a black granules are there, we always say mycetoma. If there is no black granule, we don't say mycetoma. It is not like that. There are yellow granules, there are white, and then there are red granules even in cases. Actinomycosis is basically an endogenous infection and caused by filamentous bacteria or higher bacteria. The organisms are commensals in oral cavity, alimentary tract, and vagina. Now, this is very important actually. If there is any endogenous infection, the endogenous infections are which are usually having higher bacteria. Then they are caused by actinomycetes israeli. There are 4 types actually. If you get cervicofacial, thoracic, and pelvic, they are most of the time the actinomycosis. The characteristics of mycetoma again is very important, because on this basis also the treatment modalities are based. That is actinomycetoma, which are thin filamentous, without chlamydospores. And then there is the eumycetoma, which are broad hyphae and chlamydospores. Now, the treatment modalities are substantially changed in both, whether it is the actinomycetoma group or whether it is a eumycetoma group. Eumycetomas are caused by two fungi, which has got a broad hyphae and chlamydospores. And actinomycetomas are thin filament with chlamydospore, without chlamydospore. Now, the treatment we will discuss later. Now, mycetoma has been broadly divided into two. One is eumycetoma, or what we call maduromycetoma. The schizomycetoma is second group, which is actinomycetoma and botryomycosis. Now, we frequently write botryomycosis. Botryomycosis is quite different actually. It is most of the time the bacterial colonies. Now, this is the one which is important, we should do typing actually. The first group is common etiological agents of eumycetoma. Madurella mycetomatis is the first, which is the most common. So I would like to give emphasis on the Madurella mycetomatis. Madurella mycetomatis. Here, they are actually black-grained mycetoma, number one. Number two, they have got spores at the periphery. And the second one is Madurella griseae. This is also fairly common. Now, Exophylla janselmi, previously we used to call it as Phyllophora janselmi. Then Escherichia boydii and Acromonium species and Aspergillus nudulans. This last one was also important. We hardly find any cases of Aspergillus nudulans, which has got again a yellow granules, but at the same time important because they have got a thin hyphae and lot of spores. Now, then the second group is actually actinomycetoma, which is first one with Actinomadura somulensis. It is not streptomyces now. It is Actinomadura somulensis, Actinomadura maduri, Actinomadura pelletri, Nocardia brasiliensis, and Nocardia asteroides. Nocardia is not that common. That is very simple and not very difficult to diagnose. I will talk about the first two one and even the third one also. Third one was again very surprising, Actinomadura pelletri. It is a red-grained mycetoma. You will rarely come across. If you cut sometimes, swelling, sinuses and discharging granules. If you get this triad of symptoms like swelling, sinuses and discharging granules which are rare in nature, it is nothing but the Actinomadura pelletri. The streptomyces has been changed by Actinomadura pelletri. Now, Streptomyces somulensis, or what we call as Actinomadura somulensis, is also important because this one is again different from actinomycetoma because here you get plenty of cementing substance and no spores. So that we will discuss. Now, agent causing botryomycosis are actually bacteria. They are Staphylococcus, Escherichia coli, Proteus, Pseudomonas, and Streptococcus. They all are bacteria basically. So we call botryomycotic colony. We frequently get in tumors actually wherever there is a necrosis. Now, broadly, after I am almost working from last 20 to 30 years on mycetoma. And the first 10 years, actually we have done from 66 to almost 76, 78 for almost 10 to 15 years. And we have analyzed some of the retrospective cases and most of them are prospective cases also. The farmers, laborers, housewives and shepherds, they were involved, they were having the occupation-wise. The mode of entry, if you look for, the thorn prick is the commonest actually. The thorn prick and farmers, this is a good combination by and large for most of the mycetoma cases. Injury due to glass, penetrating injuries and minor abrasions and use of wicks for removal of wax from the ear. This was the first case actually that from the middle ear, Professor K.R. Joshi has reported that the patient was using a twig and putting a thorny twig in his ear and it went right up to the middle ear and they got the middle ear mycetoma, which is quite rare. Now, this is actually a usual picture which you get in cases of mycetoma. that is the swelling, sinuses, and discharging granules. If you look at the history, this is not a new disease. It's a disease which has been mentioned even in the Atharvaveda, what we call padvelicum, that is ant hills of the foot. Now see the next picture. This is in our local language, or in Rajasthan, or particularly in western Rajasthan, we call it Kidi Nagra. Kidi is ant. So it is a city of ants, and we call it as a Kidi Nagra. And commonly in the villages, the people come with this, that is a Kidi Nagra, where you find swelling, sinuses, and discharging granules. Most of the time you can see, this is a picture which we have taken from our college, at the back of our college from Department of Pathology, where we have tried to show that this is almost resembling the soil which is having the lot of the ants which are making their houses. Again, this disease is not, again, I told you just now, there are two big colonies, basically, or two big states, northwest Rajasthan, which is Thar Desert, and the second one is actually, if you look at the south. So we had one symposia around 20 years back, around 15, 20 years back, at our place only, national symposia, where we 5, 6, 7 persons were. Madam Pankaja Lakshmi, she has also done a lot of work at Tamil Nadu and Madura. Now this is again, actually, I want to mention that in 1846, Colebrook and Madura, she has reported the... Now there is a very good co-association by and large of rainfall with the mycetoma, particularly the eumycotic mycetomas or the caused by true fungi. Now the incidence is reducing. The incidence of mycetoma, particularly the true fungi, is reducing, because now here, first let us discuss this one, the less than 350 millimeter Thar Desert, which was actually opening where you will find that northwest part, which is absolutely Thar Desert, there is a very little rainfall, and the cases are almost 5 to 6 times higher than actinomycosis. Now, if you look the picture of this map of Rajasthan, you will find that there is a good rain at the southeast region of the Rajasthan, there where you will find that rainfall is almost more than 600 millimeter. And there you will find the actinomycotic mycetoma is much common. So, if there is a Thar Desert, you get more eumycotic mycetoma or true fungi. And if there is a good rainfall, it is less number of cases. By and large, experience with most of the mycetoma cases is that age group is 20 to 40 years, where the patients are fairly active in their lifespan, and you will find the mycetoma cases. In less than 10 years, even the mycetoma has been reported, and more than 70 years, also the mycetoma. Now, this is a very good, as far as the sex ratio is concerned. The males are much more affected as compared to the females. Because previously, the male has got more outdoor activities, more involved in farming, and more involved in agriculture. Therefore, the males has got a higher incidence. Now, again, the first report or a series which was reported by Dr. Harman Singh in 1973, then 1979, then two more series were reported by me in 1979, 2006. And actually, after that only, I continued with the same, but I don't collected the data and I don't have statistical data. But I can say it, that wherever I have gone after leaving college, whether at Jalawad, whether at Pacific Institute or anywhere, I am repeatedly including the cases in my mind, not of course in the literature form. The mycetoma, the site of predilection is the rural areas. Now, out of 140, which were my first series, which has got a more maximum number of cases were involving foot, and that too in rural area. This was my conclusion from the first series. The site of lesion is actually from Jodhpur, where the foot, hand, and legs. Now, these are the three actually, where you will find that foot, hands, and leg are the most commonly involved. Few cases only has been reported from back, neck, chest, scalp, arm, and forearm. Now, because of in agriculture or because of the farming, their involvement is in in a squatting position. These hands, foot, and the gluteal regions are the one which are most affected. Now again, rural is to urban ratio is 7:3. Farmers are involved almost 66% of the cases. The common site of predilection in various etiological agents of mycetoma, foot is the one. Almost 60 to 70% of the cases are in foot only. The few cases are found in lower extremity, then hands, upper extremity, neck, gluteal region, and the perineum. Again, it is the foot where you can see the large number of sinuses which are discharging black granules. Again, this is mycetoma of foot, where there is an involvement of neck, of ankle and foot. Now, this is a good photograph. We got a amputated specimen of foot, and there we did the one sagittal section. We went to Department of Anatomy, and you will find that bones are involved. There is sorry. Now, this is a picture which I wanted to show you. Unfortunately, this is not way. This black one is actually the fungal colony of Madurella mycetomatus. And the Madurella mycetomatus, they usually involve osseous lesions are there. And here you will find that the soft tissue is involved, and you will find the amputation has to be done. If there is a bone involvement and eumycotic group, amputation is the treatment of choice. If there is no bone involvement and still there is a good sinus and swelling and all this, you have to do the wide excision of the ulcer. Now, this is here you will find that even not only the foot, you will find there are two marks which we have made. This is actually the inguinal lymphadenopathy, which also is present in some cases. Again, perianal region, you will find there is a cicatrization, and there is a top of it, you will find there is a sinus. With the sinus, you find there is a dam. The local people, because of the secondary infections, they get such types of local counter irritants by putting dam over it. Again, see the perianal region. Again, a farmer who was most of the time having very little clothes, and he was sitting on the squatting position, and you will find that there are again shoulder region, the involvement of the shoulder region, where there is a even certain cyst-like appearance beside these sinuses. Sometimes they don't come with the typical triad of swelling sinuses and discharging granules. They do get the cystic lesions. So here in the middle finger, you will find that there is a cyst-like appearance which was removed. Again, involvement of the hand and giving rise to deformity. You can see there is you can compare, the elbow has been involved in this case. Axilla and the chest has been involved in these cases. Now see the forehead, there is a cyst-like appearance which one can confuse with the dermoid, but actually it is not. When we cut it or removed it, we find that there were good black granules. So sometimes they give the atypical presentation of swelling also. Now this is again very good case which we have come in our own department later on when we were working. Me and Dr. Yogiraj has published this case also. Orbit, which is rare, but it is because of how the body is the exogenous infection. So you will find the upper eyelid, there is this case, and another one was at the patella. There also, these were the two at unusual sites we got these two cases. Now this one is extremely a very rare case, and importance of this case is that it's a labor and farmer who was actually carrying the stone slabs, which are silica mines are very common in this area. And he was taking like this at his back, and nape of neck was involved. And because of the nape of neck, there is a constant irritation at the back of neck, and because of that, he got multiple discharging sinus and infection. Because soil is the one where you find this type of lesions. Now this is a diagrammatic representation actually, that's how when the farmer works actually, his squatting position, his foot, his leg and his hands, they come in the contact with the soil, and the soil is always contaminated with the thorns and the... Now some of the picture of important species. The Madurella mycetomatis, it's dark brown or black, bilobed or trilobed. The brown cementing substance is evenly distributed. Two types of the granules are there. One is filamentous type, another is vesicular type. Thin hyphae chlamyd spores, both are terminally placed. There are two more important staining which we can do. One is PAS, periodic acid sulfate, and another is GMS, glomerulus methylamine silver. These are important. The past positivity is there in these cases, and silver methylamine will show the mycelia, spores, and cementing substance are brown-black. See this picture, please. It is very important. Madurella mycetomatis, brown, dark black granules, and you find the large number of spores and chlamyd spores at the periphery. Cementing substance is also brown-black. The reaction is always there. This is again PS staining. You can see the spores. You can see the broad hyphae also. This is the most common actually which we find here, particularly in this part of Rajasthan. Madurella grizzii, the hematoxin eosin stain shows the brown or black. Two zones are there. One is central non-pigmented, loose tangle of hyphae without spores and cementing substance. Peripheral dark colored, dense network of hyphae and cementing substance shows intense positivity on periphery, weakly positive or negative central area. Now please see this one. This is again, if you see the H and E section, you will find the peripheral is quite dark and the central area is actually practically is a light cementing substance or very light. Now see this one, the high power view, where you will find the periphery is quite dark with spores and the cementing substance in the center is faintly stained. Now this one again, the last one, the aspergillus nodulans, which I told you just now, is a young farmer, labor of Jaisalmer of Thar Desert, gradually increasing swelling, sinuses and yellowish green discharge at the back of neck, which I showed you photograph just now. And aspergillus nodulans was round or the grains are round or bilobed. Hyphae are thin, faintly staining, eosinophilic. Spores are more pale towards periphery, and splendor hopeling phenomena is there. Pigment and cementing substance are absent. The PAS and GMS both shows lot of positive mycelia. Now this one was again, which I was telling you, Thar Desert. This was a labor and farmer who was taking the bag of soil and this stone slabs on his back, and he got this. You see the large number of spores and see the hyphae which are all around it. This also we published in Journal of Tropical Medicine and Hygiene at London, and it was accepted very well because it is quite rare, aspergillus nodulans. The Actinomyces somalensis, this type of fungi, this is Actinomyces group, is another group which is very important, and large number of cases where there is a good rainfall, they come into this, and this is the commonest fungi which you feel in these cases. The granules are round or oval, longitudinal cracks, stained light basophilic, but eosinophilic towards the periphery, smooth borders, cementing substance is abundant, and you hardly find actually any spores. The pigment and spores are absent by and large. Now, the PAS and GMS are positive. Now, see this one. Now, this is the one which we commonly show it to the student also as mycetoma. This is correct. please don't label it as actinomycosis. My suggestion to you is, because many people, because in this case, you don't get the spots at the periphery. So people wrongly diagnose this case, because I have seen 2-3 persons which they label it sometimes as actinomycosis. It is not actinomycosis, it is actinomycotic mycetoma, and usually there are yellow granules. See this one, this is a very good picture, where the complete picture of the granules, where there are longitudinal cracks and bluish pink in nature. Then second one was, in this group is of actinomycotic group, is Actinomadura maduri. Grains are round, multi-lobed and irregular borders, dense filament, deep blue periphery and central pale blue. Spores and cementing substance are absent. The PAS and GMS are positive. Please see the picture. Now this is again a very different picture, where you find there is a blue fringe. There is a blue fringe, there is a deep eosinophilic blue fringe at the periphery, and rest is the cementing substance. Now this is a hyper view, you can see this one. Then this one is also very quite few cases we have come across. We have again published these cases. In Jodhpur only we have come across till today 4-5 cases. Actinomadura pelletari. The name is also given as red-grain mycetoma. This is the one with red-grain mycetoma. I remember my first case was long back, around 30 years back, when I started as my career as demonstrator or as a lecturer. Then we just cut it. There was an external mass of swelling sinuses and discharging granules. We just cut it, and we saw that a large number of red granules are, we could see. It was very unusual. Dr. Chandra will also remember, we published it. And when we saw it, the picture is so typical that I will just go through it actually. Hemiduction eosinophil stents are round, oval, lobulated, and often semilunate, again semilunate or irregular angulated border. And the important thing is it was practically like a denticulate, having denticulate margin and semilunar. Spores and pigments are absent. This is again very important. There is no spores, there is no pigment is there. Cementing substance is dark blue, violet, hemiductinophilic. That is different from that actually. PAS and GMS are positive. See this one. Again, semilunar in nature, hemiductinophilic, deep eosinophilic to hemiductinophilic. Now this one which we were discussing actually, again the diagrammatic representation. It is very common. The villages are full of our thorny trees and plants, like especially the khejadli and all these babuls. They are abundant in the rural areas, and the boys out of their they take a small twig, put in the ear, and that goes right deep into the tympanic membrane, and you get mycetoma of middle ear. See the various trees. Now see the thorns which are plentiful. Now again the causative agent, this is not my slide, again I have taken from Dr. Sangvi, who has done again thesis on the culture, where we find there is a soil, dried decaying thorns and decaying twigs, where when the culture was done, and the culture, there is the soil, the thorns and twigs, they all are infected with the mycetoma species. The typical versus atypical, again, this is my slide. Now, typical are 94, atypical are 46. Now, see this one in the interdigital space, or in between the fingers, you find there is a certain cyst-like appearances. And if you cut it, you find you get actually the granules which are black in color. Now see this one again. Now the primary osseous lesions are 2, where without involving even the leg, you get the cases. Now similarly in 20 years duration, out of 140, the foot is involved in 6 cases only. Now again, treatment part is most important. Now, these are some of the important slides which you should just try to remember. Mycetoma is eumycetoma. Surgery plus antifungal is the treatment of choice. So, surgery has to be done in all mycetoma cases. In actinomycotic mycetoma, long-term, broad-spectrum antibiotics, sulfons or sulfa, they can be given. So, actinomycosis is a broad-spectrum antibiotic. Now, if there is any fungi which is caused by true fungi, the surgery or the excision has to be done along with the antifungal and antibacterial. In actinomycosis, the broad-spectrum antibiotic will solve the problem. Now see this one, the amputation has been done because of the osseous involvement. Prosthesis has been put, and now there are just one more minute I will take, and I will show you some of the important fungal lesions. You can see the blue one, ring-like structure, multiple. This is nothing but the cryptococcosis. A large number of blue rings are there. You can see this one in macrophages. Next one is histoplasmosis. The next better one is I will show you. Now, in this histoplasmosis, you will find there are basically 2 to 4 micron bodies where there is a leishmania tropica also. You get this type of lesions. Now, here the difference between the two is here you will find, since there is a histoplasma capsulatum, you get a clear halo around it. Large number of the macrophages, they are studded with the histoplasma. Now this one, again, third one is blastomycosis, where there is the bullet-like, you get an appearance. In the center, there is a target, and this is nothing but the blastomycosis. So these are 3 slides, which is from one of my postgraduate students who was working with a lot of vesicles, HIV positive case actually, where we get cryptococcosis, blastomycosis, and this one is histoplasmosis. So, last slide, changing pattern and incidence of mycetoma. The incidence of actinomycotic mycetoma has increased during last 5 years in this part of Rajasthan due to change in the climatic conditions. Like I have written actinomycotic mycetoma has increased, not maduromycotic. Maduromycotic is vanishing actually. Now because of the heavy rainfall, increased irrigation by Rajasthan canal, urbanization of the village, and modification in means of agriculture and change in lifestyle. With that actually, the rainfall is actually increasing in Jaisalmer, Badmer, all over desert. And with that increasing in this type of rainfall, the incidence is reducing. The ratio of prevalence of maduromycotic mycetoma to the prevalence of actinomycotic mycetoma has decreased from 4:1 to 1.9:1. Now see, there is a decrease in the ratio, which was 7-8 times, has gone to 4:1 to 1.9 during the last 5 years. Take home message is mycetoma is exogenous infection, whereas actinomycosis is endogenous infection. This is the one most important thing. The second one is histological identification plays an important role in differentiating the maduromycotic mycetoma and actinomycotic mycetoma and deciding the treatment plan. So that why you should do it, the reason is only this one, that if you identify the species, you can plan your treatment. Maduromycotic mycetoma, again true fungi, excision plus antifungal plus antibacterial. If bone involvement, the amputation has to be done, otherwise it will go on coming. Actinomycotic mycetoma are filamentous hyphae and bacteria, antifungal and antibacterial. Thank you very much.
Thank you so much, sir, for this insightful presentation. Any questions from audience?
Thank you. To be here because sir has taught us this mycetoma pattern at Kota. We have learned a lot, but nowadays, as sir truly says, this is coming down and actinomycosis is going up. So PG students must be aware that
Yes.
so that's
Right.
nice weather, and thank you.
थैंक यू.
अभी गुजरात जी ने किसी कैंडिडेट को भेजा था, तो आपने जो बताया था उसके अंदर रेनफॉल अब आप ज़्यादा हो गया हमारे इरिगेशन वगैरह, तो पिछले 10 साल में मेरे 10 और 20 केसेज हो गए.
तो मैं सभी जगह मैं बता रहा हूँ आपको, जहाँ 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 रेनफॉल इंक्रीज हुई है या जहाँ भी रेनफॉल बढ़ा है, वहाँ एक्चुअली मधुरोमाइकोटिक में केसेस तो हो गए कम और एक्टिनोमाइकोटिक माइसिटोमा इज इंक्रीज्ड. पर्टिकुलरली मैं आपको बताता हूँ कि जो अपना बाड़मेर जैसलमेर का जो एरिया था, जो था डेजर्ट था, वेयर विद रेशियो वाज समथिंग लाइक 9:1, आई एम टेलिंग यू. नाउ दिस हैज कम डाउन टू ऑलमोस्ट 2 to 3:1.
Disease. The disease is being underdiagnosed. It is not diagnosed by somebody. ऐसा प्रतीत होता है मतलब मेरे को, क्योंकि we are still getting about 20 cases per year. And
जोधपुर के अंदर
from April to December, we have started a established center at MG Hospital Jodhpur, and I have got 8 cases of the mycetoma. So I
But
don't think it is a
similarly-
decreasing, but there is definitely changing pattern from eumycotic to actinomycotic.
Yes, agreed.
But the disease is being underdiagnosed, what I think.
No, I agree with you. That's the second part. The underdiagnosis is of course there. I was at Pacific Institute of Medical Science at Udaipur, and before that actually no case. And when I was there, almost 10 cases. Almost 10 cases
So it's being
in 1 year.
underdiagnosed. And I have a collection of last 20 years, and I am having more than 180 cases of mycetoma.
Yogaraj, let me add one more thing
So
actually.
it means that the 20 cases I am receiving per year
Yogaraj,
at one center only.
Yogaraj, you please make the statistics actually after that. My doing 140 cases. One thesis was done by Dr. Deepa Mathur for 10 years for DNB purpose. And second thesis was done by Rashmi Bakshi, where again for 10 years. So that 20 years I have not published so nicely, except for one changing pattern of mycetoma.
There is a
That was
changing
in Indian Journal of
pattern
Path and Micro. Almost I have written 13-14 papers. So if you summarize it actually, you can complete for another 25 years. You
I
can
have
publish.
got 25 years cases.
So you
It
should
be published, sir.
publish it.
Sir, last 5 to 10 years, the rainfall in Jodhpur region is decreased as compared to Bikaner.
Yeah.
400 plus. Before it is about 50 or 88. Here it is decreased.
Yeah.
So this is their increasing. Here,
Yeah, here they are increasing and there it is reducing.
Yes.
Organization by the senior professor, histopathologist, Professor D.R. Thanks.
Now I'll request our respected chairpersons to felicitate Dr. D.R. Mathur sir. I'll request Dr. Manju Bohra ma'am to come up on stage and felicitate our chairpersons. For our next lecture, I would like to invite Dr. RAJPATHCON ma'am, Senior Professor and Head of Department of Immunohematology and Transfusion Medicine, Dr. SN Medical College, Jodhpur. Additionally, she is also working as Medical Superintendent of Mahatma Gandhi Hospital, Jodhpur. She is well known for her outstanding work in increasing voluntary blood donation, and honored by district, state government, and various NGOs. This session will be chaired by Dr. B.L. Jain sir and Dr. S.R. Negi sir.
And it's a very simple and basic, but it is very important for the users. So when it is important for the users, it is important for us also ki whatever we are giving to the demanding clinicians, whether it is correct or not, it is given to the particular disease, for the particular disease, or we are giving unwanted components. So for that particular thing, it is important. Now, what are the main topic is rational uses of blood and blood products. The term rational use of blood component denotes the importance of using right product at right doses, at right time, at the right patients, and for the right reason to decrease morbidity, mortality to its maximum extent. Now, what are the significance of blood component? As we know, initially we were using blood, whole blood. But as the diagnostic skills and the knowledge of disease process improves, the whole blood become insufficient, and now we are using the blood components. Now, the significance of blood component is, as we all know, 1 unit of blood collected, it is benefited to more than one patient. It is benefited to 4 to 5 patients. We are giving 1 unit of blood to the 4 to 5 patients or different components. The specific components, second important, very important, significant is the specific components as required can be given in adequate concentration for better patient's care without danger of overloading the side effects. It is very, very important because suppose the patient is of anemia and we are giving whole blood. So what we are doing, we are putting a circulatory overload to the patients and we are harming the patients instead of benefiting it. So it is very important to give this. This is the most important significance of the blood components. Now, our blood center plays a very major role in separation and proper storage of red cells and plasma components into its further derivatives. It is delivered only after meticulous pre-transfusion testing as per standard protocol. Now, this topic mainly focuses on the clinical aspects of proper separation of blood components, its uses in healthcare management. Knowledge of prescribing appropriate, safe, and concentrated dose of required component is essential. Now, what are this picture shows just the component of the blood. As we all know, the blood have the 55% is plasma and 45% only the cellular components, which contain white cells, platelets, and red cells. Now, what components are we can prepare from a single donor, single bag, from single whole blood. Now, the whole blood and this table is showing the storage and the shelf life of the whole blood and its component. The whole blood storage is 2 to 6 degrees centigrade temperature and the shelf life is only 35 days. Now, about the different types of red cells. All the packed red cells, liquid depleted red cells, irradiated red cells, these are all stored at 2 to 6 degrees centigrade, and the shelf life of packed cells is 35 to 42 days nowadays because we are using Sagum. And the storage of frozen red cell, it is minus 80 degrees centigrade and it is stored up to 10 years. Now, the platelet components, the platelet concentrate, it is stored at 2 to 24 degrees centigrade and for 5 days. Granulocyte components, this is storage temperature is same 20 to 24 degrees centigrade, but only for 24 hours. Now, the plasma components, these are fresh frozen plasma and the cryoprecipitate. The storage is minus 40 or below and it is stored for 1 year. Now, these are the potentials of human blood, the components which we are preparing at our blood center. These are red blood cells, fresh frozen plasma, concentrated platelets, and cryoprecipitate. Now we will discuss in very form about the indications and contraindications, side effects of all the blood and its component. The whole blood, what is whole blood? It contains, as we all know, all the cellular and the component parts of the blood which we have taken. Indications of whole blood is limited. It's only in two conditions. Number one, whenever there is a dual problem of anemia and hypoxia, hypovolemia, then only we should use the whole blood. As I have just discussed, if the patient is having only anemia, never use whole blood. So whenever there is a dual problem, in that only. And then the second indication is exchange transfusion. Now, what are the contraindication? We are telling the same thing again and again. Anemia without hypovolemia, never give whole blood. Then never give whole blood or any blood product for a volume expansion, because as we know, every blood component or every human product, they have no zero risk. Always there is a risk, even after taking, doing the testing, even that tested blood is given, there is no zero window period. So never use blood for a volume expansion. Now, then other contraindication is a coagulation factor deficiency. Coagulation factor deficiency, never use whole blood, it is of no use. We should give a particular coagulation factors. Now, what are the hazards of whole blood? The number one, hemolytic transfusion reaction, then the transfusion transmissible diseases, as I just said, there is no zero risk. So, then the febrile reactions, allergic reactions, circulatory overload, metabolic complications, and graft versus host disease. Now, this picture showing how we prepare the different components from whole blood. Now, the red, we will discuss about the, coming to the components. Number one, these red blood cells. What are the red blood cells? Red blood cells is the cellular product achieved after centrifugation of the whole blood and removal of most of the plasma. Nowadays, as we are using SEGM, we are removing most of the plasma. And indications of red blood cells are severe anemia to reduce chances of circulatory overload. Hemolytic anemias, especially in aplastic crisis, various hypoplastic anemias, various aplastic anemias, anemia accompanying the chronic renal diseases. Now, what are the contraindications of RBCs? As we should never give blood if there is a nutritional anemia. Better to give supplement instead of giving the human product. Same thing, never for volume replacement, better give crystalloids, colloids for the solution, not as a human product. And then in case of hematinics, to enhance wound healing, to improve general well-being, never use the blood. Now, this is very important for us. Though the clinicians demand blood, but it is up to us whether we should give or not. So we should know the trigger of the transfusions. If the hemoglobin is less than 6 grams per deciliter, then only transfusion is required. But whenever there is a surgical risk and anemic hypoxia, in that case more than 6, but not more than 10, 8 to 10 grams per deciliter is the transfusion trigger. But in the patient's risk of bleeding, and in the then 6 to 10 grams per deciliter is the transfusion trigger. For cardiac surgery, if the patient is undergoing cardiac surgery, then not less than 6 grams, less than 8 grams per deciliter, then it requires blood transfusion. Now, this leukodepleted products. Leukodepletion is a process by which leukocytes are removed from donated blood. Most of the leukocytes, more than 70% leukocytes are removed. Now, it is indicated in multiple transfusions, as we all know, because, in cases of thalassemia, dialysis, hemophilia, wherever those patients are there requiring the multiple transfusions. And in the patients undergoing bone marrow, renal and organ transplantation. Leukodepleted blood have advantage. What are the advantage over RBCs? advantages are reduction in febrile non-hemolytic transfusion reaction, as we are removing the most of the leukocytes. Then prevent alloimmunization to HLA antigen. Then reduction in CME cytomegalovirus transmission reaction, as we know it is present in lymphocytes, so we are removing most of the lymphocytes, it is preventing. Now the reduction in transfusion graft versus host disease, reduction in transfusion related acute lung injury. This by using leukodepleted blood we can prevent all these, and these are the advantages. Now this is the leukodepletion prepared at the blood bank. Coming to the frozen red cells. Frozen red cells, the indication of frozen red cell as it is used for a very rare blood groups storage, for Bombay group, for even A2 or A2 variants, antibodies against high frequency antigen, and autologous transfusion also. Some may deposit and store the frozen red cell, though we are not having this facility of frozen red cells. Now the irradiated red cells, these are they are receiving cellular products from their sibling parents for congenital immunodeficiency disorders, for the acute leukemia, Hodgkin's disease, and severe aplastic anemia. These are the indications of irradiated red cells. Now coming to the other cellular component is the platelet components. Platelet concentrates, which we are preparing at our blood center, that they are from a single donor, and the indications are A megakaryocytic thrombocytopenia, leukemia, wherever there is, I want to say when there is a cases of thrombocytopenia, whatever the reason, either A megakaryocytic thrombocytopenia, leukemia, aplastic anemia, chemotherapy, bone marrow transplantation, marrow infiltration, or radiation induced, massive blood transfusion, DIC, and dengue. Now, what is the contraindication of platelet concentrate? When it should not be given? Whenever there is a bleeding unrelated to decreased or unrelated to the number or function of the platelets. It is not concerned with the platelet, never give platelet concentrate. Patients with ITP. Again, I will say patients with ITP, it is not at all indicated, but still we are giving because for a symptomatic relief. Patients having bleeding, so we gave platelets just for the symptomatic relief, as it is autoimmune disease, is not corrected by platelet. So now, what is the concentration, at what level we should give? Again, the transfusion triangle should be this in platelet concentrate. The 1 unit, the doses are, whenever there is a platelet, see, we'll come to this one first. Whenever the platelet count is less than 5,000, with no any complications, platelets are given. It should be indicated. Or patients are, or other patients undergoing any surgery, any invasive procedure, in that case, if the platelet count is 50,000 or below, then it is indicated. Otherwise, platelet concentrate, never give platelet concentrate, which we say is RDP. Now, what are the doses and administration? 1 unit of platelet count, it raises 5 to 7,000 per cubic millimeter in adult 60 to 70 kg body weight. Hence, the usual dose for an adult is 6 to 10 units. In children, the dose is 1 unit per 10 kg body weight. In units, it's 1 unit per 2.5 kg body weight. Sometimes we expect very less increase, not this increase rate is there in, though it doesn't mean that our quality is not good, but this might be because of, in cases of DIC, sepsis, splenomegaly, platelet or autoantibodies, chemotherapy, we won't get as our expectations. Now, that's all about the cellular component. Now we will coming to the plasma component. Plasma components, the fresh frozen plasma, FFP. What is fresh frozen plasma? It is a plasma which is separated in 6 to 8 hours of collection, and then it is snap frozen as -40 or below. This is known as fresh frozen plasma. It contains all the coagulation factors. These are the ingredients which is present in the FFP. The maximum it is as a fibrinogen and the factor 8 and vulnerance factor. Now, the indications of FFP. The absolute indication of FFP is TTP, thrombotic thrombocytopenic purpura, and the other indications that include severe liver disease or who have given coumarin anticoagulants, DIC, dilutional coagulopathy, replacement of the single factor deficiency. If there is any factor deficiency, we should give. Now, what are the contraindication? Never use platelet as a volume expansion. Neither whole blood nor platelet, nothing. Any blood component, any body component should not be used for a volume expansion. Then even never use FFP for a hypoproteinemic patients. Initially, we were getting from a chest and TB hospital for FFP just because they are patients of hypoproteinemia, but we should not give. It is our duty to explain them that the risk of the patient will be more than the benefiting, and never give for an immunoglobulin replacement. Now, what are the adverse effects of FFP? Allergic reactions. Mild allergic reactions in almost 60-70% patients we are getting urticaria rigor, but severe hardly anaphylactic reaction, though it is seen in IgA deficient person with anti-IgA. Now the circulatory overload, we have just mentioned ki plasma level, if we give more, that may cause the circulatory overload, alloimmunization, and TTD. TTD transmission is always, we should have it in mind that this might happen because there is no zero risk. Now the doses, what are the doses of FFP? The doses of FFP, it is 12 to 15 ml per kg body weight. It requires 4 to 5 FFP bags for 60 to 70 kg body weight. FFP, before giving, it is thawed at 37 degrees. As we know, the name, fresh frozen plasma. Frozen is, we have freezed and we are preparing fresh within 6 to 8 hours of collection, but then we are freezing at minus 40 or so, it is a stony hard just like a ice. So it is before giving it is thawed at 37 degrees centigrade whatever, and this after thawing it is better to use as early as possible to maintain the functions of the coagulations factors. So if sometimes they says no, we are not able to use now, so we can keep it in our refrigerator for 2 to 6 degrees centigrade for 1 day, only for 24 hours. After that, if they are used, give the another FFP. Preferably, it is given ABO blood group specific. RH negative patient, RH negative plasma should be given. This we should have in mind. Now, the cryoprecipitate. What is cryoprecipitate? It is an insoluble portion of the plasma remaining after FFP has been thawed at 2 to 6 degrees centigrade. And the constituents of it is rich in factor 8. That is why it is given in hemophilia patients. Vulnerance disease, fibrinogen, factor 13, fibronectin, small amounts of factor 9, factor 10, factor 13. Now the indications of cryoprecipitate. In hemophilia, as it is rich in factor 8, so hemophilia patients, vulnerance disease mein factor 13 deficiency, even in massive blood transfusion we are giving. Then DIC patients, we are getting from the gynae patient, most of the DIC patients, what they require, what they do, they send us for the FFP, they send us for the cryoprecipitate. Manju madam is having good experience and facing this problem every day. So, and they take platelet also. So, our duty is to say that instead of giving FFP for the DIC patient, better give cryoprecipitate, so that we can give, we are giving the less volume of the blood and better concentration of the coagulation factors. Then, doses of cryoprecipitate is 1 unit per 10 kg body weight. So the same at least 5 to 6 unit for 60 kg body weight person it is required. Now the half-life of factor 8 is only 8 to 12 hours, hence it is repeated after the 8 to 12 hours of the interval. No compatibility testing is required in this, just thaw and give. Just use this, the difference is FFP and this, it is used within 6 hours. There we can keep it for 24 hours, this we can keep only for 6 hours, and otherwise it is better to give just after thawing. Now, These are all the components I discussed, which we are preparing at our center and we are giving. Now we are having the excess plasma also. For excess plasma, we are sending to the private laboratories for fractionation of the protein. They are using for the preparing the albumin and all the globulins. These are the vials which they are preparing at the center. And these are the products, their composition, their indications for all the the plasma which we are giving to them and preparing. And these are all indications for volume expansion, albumin, factor 8 for hemophilia, and like this, all the factors. Thank you.
Thank you so much, ma'am, for such informative lecture on rational use of blood and its components. Any questions from audience?
Well, thank you, Dr. Rajshri, for such a wonderful and informative presentation.
Thank you.
As we already know, the demand of blood always outpaces the supply. So in that way, that can be only managed when we have to use it judiciously. So in
Yes,
that way, in this context, the appropriate and the rational use of blood is very important. Moreover, as you have rightly said, it is a zero risk. There is no risk. It is said that the safest transfusion is no transfusion.
No transfusion.
That is the best adage. So in that way,
Yes.
in this context, the rational use of blood is very important. Thank you for such a nice presentation.
Our role plays here only, where to give or not to give. Their demand is always there. Clinicians always demand us, but it is our role whether we should give or not.
In this context, I would also like to congratulate and remember Dr. N.M. Mehta.
He
was the pioneer.
Even I want to congratulate.
I learned a lot
I am
from him.
really grateful
Yes.
and thankful
Really
to sir. So because I
Thank
am
you.
basically pathologist, but I worked under sir since for about 20 years, and this is my first posting. I worked in blood bank. Otherwise, when we were PG students, we were not posted in blood bank. So sir taught us a lot, and even after working with sir, I developed interest in transfusion medicine, and I opted this subject also. Thank you, sir.
Exactly. Yeah. Dr. Mehta conducted along with his. Yeah. All the me and Dr. Rashri will preparing for practical session. Yeah. Yes, under the Dr. Mehta's guidance.
सर ये तो सर ने बताया था वो नेगेटिव सेंसिटाइजेशन वगैरह बनाना वो किसी को नहीं आता सर भी अगर पूछे तो रेजिडेंट को भी वो सारा सिखाया था सर ने
And sir, I want to share an information that this year with the efforts of Dr. Manjubhara and myself, we again got 4 PG students also. 4 residents also.
4 resident
Very good. Madam also worked hard since she was trying since 10 years.
Dr. Rashri, are you using the liquid depleted?
No, we are not using liquid depleted because has been used at the transfusion site at the bedside. They are using a filter, and that claiming that they are separating 99% of the leukocytes.
But bedside filter are they have the same problem, but better.
We are not having this, because the thing is that it is very expensive also. As you know, how much blood is to be prepared as a liquid depleted, we cannot anticipate.
Because in Saudi, we almost 95% we are preparing liquid depleted.
Now I'll request Dr. B.L. Jain sir and Dr. S.R. Negi sir to felicitate Dr. Rajshri Behra ma'am. Now I'll request Dr. Rashmi Sharma ma'am to come up on stage and felicitate our respected chairpersons. Everyone must be starving now. Now let's break for lunch. When we return, we will hear from Dr. Kishore Khatri sir, our last speaker for the day. Thank you everyone. Please enjoy your lunch. Hello.
Our next scientific session is by Dr. Kishore Khatri sir. Sir is professor in Department of Pathology. Sir has done his MD from SMS Jaipur. He has special interest in cytology and gastropathology and developed gastropath section. He has been invited as a faculty in many national and international conferences. Recently, sir has formulated a plan guideline to see endoscopic colonic biopsies for the beginners, and he got copyright from India, Canada, and today in UK also. I would like to invite Dr. Kishore Khatri sir on the stage. I would also like to invite Dr. Sunita Agrawal ma'am and Dr. Ankita Goel ma'am. Dr. Nirupama ma'am, please. Dr. Sunita Agrawal ma'am is also professor in Department of Pathology. Sir will be presenting his views on processing and handling of GA endoscopic biopsies, beginner's approach.
Good afternoon all. Thanks Kanchan for this overpraised introduction. My topic is processing and handling of endoscopic GI biopsies. As we know, Madam Nirupama has already discussed various diseases of GI and we've seen in GI endoscopic biopsies and discussed various aspects, various variants on histological features. I will be discussing processing and handling to ensure that we have a very good section, adequate section, so that is really interpretable. Otherwise, you know, GI endoscopic biopsies are very small. So if they are not processed properly, not transported, fixation, section cutting and staining, then the whole exercise is really spoiled. Now, we will discuss this aspect in what are the various sites from where biopsy should be taken and number of biopsy fragments that are minimum, then mounting on various media, fixative solutions, fixation time, how to transport to lab, how to do grossing, embedding, section cutting, and then interpretation. There are various guidelines. I have compiled these various guidelines from different articles, but the main thing is that how patient has presented and what are the various endoscopic findings. So your endoscopist make a endoscopic opinion, and accordingly they have to take biopsies. Like gastroesophageal reflux disease, biopsies are directed to irregularities of the mucosa if clinically appropriate. Otherwise, there is no need of taking any biopsy. Barrett's esophagus, we have Seattle protocol. If there is no dysplasia endoscopically, then biopsies are 4 quadrants, each at 2 centimeter distance. And if they are suspecting dysplasia, then 4 quadrant biopsies, each at 1 centimeter distance. Eosinophilic esophagitis, we need biopsies from proximal as well as distal esophagus. In infectious esophagitis, as you know, we had the case of CMV colitis. As these CMV viral cytopathic changes are seen in stromal and endothelial cells, so we need a biopsy from ulcer where we can see a blood vessel. If we are suspecting herpes simplex in esophagus, then these changes are seen in epithelial cells. So we need biopsy from the edge. Then if we are suspecting Helicobacter pylori, then there are Sydney protocol where we take biopsies from five sites. One biopsy should be from the lesser curvature of antrum, then greater curvature of antrum, incisura angularis, and greater curvature of, three biopsies from corpus and 2 biopsies from antrum. Then we individually grade the atrophic changes or presence of Helicobacter pylori, and then we formulate there is a very good table in the literature, that is Olga staging. So there are 4 stages of Olga of atrophic gastritis that may be related to H. pylori or non-H. pylori. Now, if we are suspecting gastric polyps, endoscopically gastric polyps are there, then if polyp is solitary, then polypectomy should be done. If polyps are more than 1 centimeter, hyperplastic polyps more than 2.5 centimeters should be removed. If there are multiple polyps, the largest polyp should be removed and representative biopsies should be taken from the smaller polyps. Hyperplastic and adenomatous polyps, there are protocol for environmental metaplastic atrophic gastritis. Peptic ulcer disease, multiple biopsies, more than 8 or more than 8 fragments should be there. It is recommended. If there is malignancy, if there are suspicion of malignancy, in cases of celiac disease, it is recommended that we should have 4 to 6 biopsies from duodenal bulb and distal duodenum. Various literature, various articles have recommended that at least 1 biopsy should be there from your duodenal bulb. It will increase your sensitivity of diagnosing celiac disease from 70 to almost 86 or 87%. In microscopic colitis, we need biopsies from ascending colon, transverse colon, descending colon, and sigmoid colon, and every biopsy site should have at least 2 fragments. For the diagnosis of inflammatory bowel disease, we need 2 or more biopsies from 5 different locations, including ileum and rectum. That is the same. We have a representation should be from the whole colon. If we are suspecting dysplasia, we are screening for dysplasia, patient is already known case of IBD, then in that case biopsy should be taken from every 10 centimeter length of colon. In pouchitis, multiple biopsies from pouch and afferent loop. In colonic polyps, small polyps should be removed, larger polyps should be removed by polypectomy. And if we are suspecting acute graft versus host disease, then 4 or more biopsy from the rectum or sigmoid and 4 or more biopsies from the left colon, because this is the commonest site of involvement. All individual biopsy fragments should be separately mounted on a 1 centimeter square sized rectangular piece of Whatman's type 1 filter paper. What we have seen in last 2 years, that these biopsies are just taken from the forceps and biopsies are just dropped into formalin. They have a contraction artifacts. It should be mounted, each fragment should be mounted on filter paper. We should wait for 20 seconds or so that protein will be coagulated and the biopsy tissue will be adhered to the underlying paper. Endoscopist plays an important role in the biopsy orientation and mounting them in mediums. There are various mediums. After gently separating the biopsy fragments from the endoscopic forceps by needle tape, that is very important for endoscopist, without causing any crushing artifacts, keeping the shiny mucosal surface up. Now this is the technique where we can avoid various artifactual changes that are very important in diagnosis of celiac disease. You take the biopsy, if you see biopsy macroscopically with the use of hand lens, the surface is shiny. That shiny surface should be placed towards us so that the muscularis mucosa part, the epithelial part should be on your Whatman filter paper. Biopsy fragment mounted on tissue paper face down can cause artifactual mucosal flattening and best be avoided, because this is a very common artifact. Patient doesn't have any evidence of celiac disease, but microscopy shows flattening. So over enthusiastic pathologist can just say yes, it is villous atrophy, while this is not villous atrophy. That needs to be taken care of. Then 10 to 20 seconds, we should wait for 10 to 20 seconds after. That will result in addition of the biopsy fragments to mounting media by coagulation of plasma proteins. Now these biopsy fragments added to a filter paper should be dropped in 10% neutral buffered formalin, keeping the tissue face down so that the fragments do not fret away. Now the tissue which has been adhered to the filter paper, that should be put it down in this way so that the tissue is facing downside. Do not press biopsy fragments with forceps, fingers or glass slides, as they cause irretrievable damage. Now fixation, as we all know, we should use 10% neutral buffered formalin. What we are practically doing, we are just one of the technical person in endoscopy room or even in the theater, what he is doing, just taking formalin in a jar and tape water is added without actually having 10% solution. Even many of the clinicians don't know how to make 10% solution, because your original formalin, pure formalin, is just 36 or 40%. Now how to make it 10%? To add 90%, 99 times volume of water, or how much? So that is a big issue. Then that formalin, because what normally happens, that formalin vapors are dissolved in water to make it a saturated solution. Only 40% that saturated solution will be of, or just 40% concentration. So that 40% formalin is actually considered as 100%. Now we have to consider it as 100% and make it 10%. Then we have to add, to make it, over the time this formalin will be oxidized to formic acid, and it will deteriorate in quality, and subsequent staining will be not of that good quality. So it should be buffered. So to neutralize that formic acid that is formed over the time, the usual practice is to put some chalk, writing chalk we use on board. That is a usual practice. Picric acid based fixatives has fallen short of routine use, and it leads to tissue pigmentation. So that is not desirable, any sort of pigmentation, whether it is of formalin pigment or picric acid pigment. Formalin can also produce tissue pigmentation if the pH of the solution is 5.5. So we need buffering. Avoid using undiluted 40% formalin, as it produces a chairing artifact, making subsequent interpretation difficult. This is also a practice. If you call your clinician that we are not having biopsies in formalin, they will use pure formalin. So that is also not desirable. Avoid unnecessary heat to avoid producing smudgy or washed out nuclei appearance with inappreciable chromatin details. Now fixation time. An optimum fixation time for small intestinal mucosal biopsy is about 5 to 6 hours. If biopsies are left in formalin for more than 36 hours, especially on weekends, the tissue becomes hard, brittle and difficult to cut. Fixing the biopsies in formalin for a prolonged time also leads to loss of immunoreactivity, and this we have seen these cases. So we have applied some antibody there, and 2 times, 3 times repeating it, but there is no staining. So this is all because of overfixation. We don't need it. The ideal volume is 25 to 10 to 1 to generate optimum osmotically driven forces, but I think what they are sending biopsies in urine container, the volume is, for practical purpose, volume is good enough for proper fixation. Then how this biopsy should be mounted on a filter paper, face up, shining surface should be face up, then entire your paper mounted paper should be placed in formalin container face down. Transport should be as soon as possible at room temperature, no freezing, no microwave, no heating. The filter paper mounted biopsy fragment should not be separated, and individual mounted biopsy fragments should be wrapped in a bigger piece of filter paper during grossing, like an envelope, keeping the mucosal fragments up and kept in a cassette. So we should not remove the biopsy fragments from the filter paper. You put this filter paper as such in a bigger filter paper, that is a usual practice. Less than 4 biopsy fragments should be put in one cassette. If we have more than 4 biopsy fragments or multiple biopsy fragments, we have usual tendency to put in all in one cassette. So that is not desirable. Post trimming, at least 5 step sections should be cut from formalin fixed tissue block, keeping the level 1 cut towards the slide level for identifying the sequence of step sections during light microscopy interpretation. Of all the step sections, the most oriented step section should be marked for future reference. The biopsy should always be accompanied by a properly filled requisition form, mandatorily a history of medications, especially olmesartan is known to cause celiac-like changes. Then non-steroidal anti-inflammatory drugs, angiotensin II receptor blockers, proton pump inhibitors, various chemotherapeutic medications and anti-PD-L1 medications should be mentioned. Post-fixation, identification of mucosal pole is difficult due to change of color of mucosa to tan brown and loss of mucosal shine. In most situations, the muscularis mucosa contracts, that is very important. Muscularis mucosa will be contracted in formalin, leaving the mucosal surface on the convexity of the contracted biopsy fragments. That can help in proper orientation of tissue. Garg et al. Compared the orienting free-floating biopsies sent in containers over biopsies mounted on Whatman filter paper and lens papers with and without application of albumin as an adhesive substance during grossing, and found that with the use of lens paper and albumin, the percentage length orientation of the biopsy fragments were best. Whereas those mounted on Whatman filter paper only without any adhesive, they were not that good. Although that is a comparative study, but the worst orientation is when we put the biopsy freely in the formalin without any mounting. Now, there is one study from veterinary science. What they have done, that they used 3 mounting media. One was your filter paper, other was your thin cucumber slice, and third was artificial gel. So the results of artificial gel, biopsies mounted on artificial gel, were the best, and worst was the your filter paper. So what they have recommended, that if you have cucumber slice on which you have mounted the biopsy, and we have received that cucumber slice, we should not remove this cucumber slide. That cucumber slide as such should be placed in your cassette, and section should be cut. So it should not be removed. Now, thickness for interpretation. Recommended thickness is 4 micron. This is important specifically for the celiac disease, because as we know, for normal intraepithelial lymphocyte count is less than 25 per 100 epithelial cell. If they are 25 to 30 intraepithelial lymphocyte, this is known as borderline intraepithelial lymphocytosis. For Mars grading, we need more than 30. But that will also depend upon the thickness of section. If we have a section of 6 micron, then 25 or 30 figure, that will not be appropriate. In that case, we have to standardize it, and various studies have done. They have recommended that if you are using 6 micron section is the standard as in your lab, then it should be somewhere 35 to 36 intraepithelial lymphocyte per 100 epithelial cells. So better, as we are following the Mars grading, so it will be better to have a section that is 4 micron thickness and use 25 or 30 as your cutoff value. Now, how a oriented biopsy looks like, we can see in figure A, there are villi which are parallelly arranged, and crypts are horizontal. Crypts are also parallelly placed, and they are elongated. In section D, you see crypts are round. The round crypts, we have multiple round crypts, that is not considered as a well-oriented biopsy. How to see villus atrophy, normal villi, and how to take the length of crypts and consider the ratio of villus to crypt ratio. Now we can see here, these are the villi, and these are the crypts. These are muscularis mucosa. Now we can see here that the surface is flattened, no villi are seen, and there is crypts which are elongated. So this can be considered as a oriented biopsy. Now what we need to see here, that is a flat biopsy. We can see here the sort of villus which is almost flat. Then take a shoulder here, and this length and this length should be compared. In Mars grade 3, 3A, where we see villus to crypt ratio 3 to 1 or less, 1 to 1 is almost equal to 3B grade, and less than that, that is crypt is hypertrophy, villi almost flat or ratio less than 3 will be considered as Mars grade 3C. The same image oriented gastric biopsy should look like this with musculus mucosa as is standard guideline. Oriented colonic biopsies with the cigar shaped or test tube in rack position of crypts. Now there are various biopsy trauma during sampling, maybe tissue fragmentation or crushing artifacts, denudation of epithelium. All these things can be seen in a biopsy once we have that section, but still we need to see whether this section is interpretable or not. So that is very important. Now macroscopic description, once we received this biopsy, oriented biopsy in our gross room, then every number of fragments should be written. Three-dimensional measurement of every biopsy fragment should be mentioned. Individual biopsies, the endoscopic biopsies may be processed and embedded either as individual samples or more usually combined into one multi-cassette. Multi-cassette, we are not using multi-cassette. The use of multi-cassette is not only cost effective, but it also speeds up reporting time by the consultant. This is the picture of multi-cassette, basically a single cassette with multiple wells. So biopsies can be placed in this wells, but we need to take care that this cassette itself is not lost. That is a usual practice. Sometimes we lost this, we lose this cassettes. और आपका टेक्नीशियन बोलता है कि सर कैसेट ही नहीं मिल रही, ब्लॉग मिल ही नहीं रहा. This is the summarization how biopsy fragments should be mounted on filter paper, then how to put it in formalin, and how the sections should be cut on slides. These are example of these biopsies mounted on various medias. You can see in this picture. These all are the vegetable cells of cucumber slice. This is the picture of microscopic photograph of biopsy which were sent directly in formalin without any mounting media. So you can see the changes, difference in the quality of sections. Again, you can see the same biopsy which were mounted on cucumber slice with these vegetable cells. We can see the length of this biopsy. And we can see the length of your biopsy. The epithelium is here and here, both sides. That is not normal. So this is unoriented biopsy. If you consider this length of the villi, there is villus atrophy with the cryptal areas, lamina is widened. It should not be interpreted for celiac disease. Thank you.
Hello.
Thank you very much, sir.
Thank you. Thank you, Dr. Kishore, for nice presentation and considering the basic and practical problems which we are facing in routine to day-to-day practice. And I think the problem begins from the operation theaters only. So we should reach them also. And it was an excellent presentation and enlightening the residents and faculties too. Thank you very much.
I would like to congratulate you. Really made a very basic and very good presentation, which is very, very important to start with.
Thank you.
Any questions from audience?
Microwave processing we are not using, so I don't have any experience of microwave processing, but what they recommend that should not be, because these tissues are so small that it doesn't take a lot of time to actually fix, to get fixed. So I think by the time tissue is put in formalin and the patient comes to us, and at the time of grossing, 2 to 3 hours it usually takes. And an ideal recommendation time is 5 to 6 hours. The time lapses, and I think we don't have any experience.
माइक्रोवेव में तो ऐसे भी टाइम कम ही देते हैं. रिसेंट डेटा से जो भी आया है, माइक्रोवेव इज प्रिफर्ड. स्मॉल बायोप्सी में माइक्रोवेव प्रोसीजर इज प्रिफर्ड.
But sir, various studies actually, there are studies favoring these microwave processing of the tissue, but what various studies have also recommended at the same time, that is the opposite side, that there should not be heating of this tissue. So, yeah.
We used to do this microwave processing way back in 1997, and Dr. Balraman Nair, coming from Chennai, from Trivandrum, he suggested that endoscopic biopsies they receive by 12 o'clock. Half an hour for fixation in formalin, buffered formalin in microwave, and then 4 changes of alcohol in microwave, 5 minutes each, 2 changes in chloroform in microwave, go for embedding and sectioning. So the tissue received by 5 o'clock daytime, by 6 o'clock the reports are out.
Yes, sir, but in that case, we have to be very sure that these biopsies are actually mounted on filter paper. Otherwise, any sort of external temperature variation, that will cause artificial changes.
For that also he suggested a solution that in the microwave, the cassettes are put in a smaller beaker, and because the heat is generated. So in the same microwave, put a 2-liter beaker filled with water, so that most of the heat is absorbed by that 2-liter water, and the tissue will not get heated. So that heat artifacts can be avoided. We used this technique for almost 3 years, but then we had some problem with the microwave itself, and we didn't buy a new one, so we left it. But while we were doing for 3 years, we were giving report earlier, and the reports were satisfactory.
Actually, sir, this your experience of putting that water to absorb the excess heat should be published. Actually, this is no. It needs that is your local your local issue which was solved by you. But in literature, actually, I have not come across this type of thing. I am not aware of this. But yes, your procedure should be standardized and should be published to make other people's benefited.
स्मॉल बायोप्सी के अंदर तो आधा घंटा एक घंटे करके सेम डे ही रिपोर्टिंग का लिखा हुआ है. मॉर्निंग में आप डालेंगे सुबह 9 बजे, इट विल बी फिक्स एट 1 o'clock विदिन 4 or 6 hours. ये भी लिखा हुआ है, WHO में लिखा हुआ है इतना सारा.
हाँ सर, वो लिखा हुआ है, लेकिन जो
छोटी बायोप्सी के लिए
ये सर, लेकिन जो प्रोसेसिंग टिश्यू है ना, जो प्रोसेसिंग का जो प्रोसीजर है, उसको मॉडिफाई किया जा सकता है फॉर स्मॉल बायोप्सी, एंड दिस इज अ स्टैंडर्ड. यस,
मैं उसको ट्राई कर रहा हूँ कि बायोप्सी छोटी लेके देखते हैं उसके रिजल्ट कैसे आते हैं. वो पोस्टमार्टम में कर रहा हूँ पहले.
ओके,
अगर पोस्टमार्टम में अगर रिजल्ट अच्छे आते हैं तो वी कैन रन द स्मॉल बायोप्सी इन द मॉर्निंग आवर्स, डे टाइम. उसके बाद में जो आफ्टरनून में बड़ी वाली चल जाएगी. सर नहीं, सर दूसरे सारे उन्होंने बताया था मेरे को ऐसे करो आप, राइट. पहले पोस्टमार्टम टिश्यू में वी कैन टेक अगेन छोटा छोटा लेके सर भी तेरे माइक्रोवेव कर लीजिए, ये भी करें, जल्दी भी क्या.
Sir, processing of biopsies in patients who have a growth, it is very helpful in letting out the report by evening, where a growth is suspected, and we had done this with, I had the opportunity to work with sir, and we did report it by the evening. It is just like a frozen section, we give the report the same day. If we are giving a report of a malignancy same day, it helps the patient. Yeah, it is better than frozen section, of course, because there are no artifacts.
24 hours is sufficient for giving the report at the earliest possible.
वो ये इसलिए है that all this
With all these processes, we can give report in 24
report
hours.
can be given in 24 hours, but we are working in an institute where after 6 hours lab is closed.
You can change your institute time also. It depends upon you only.
एक्चुअली जो गैस्ट्रोएंटरोलॉजिस्ट जो रिपोर्ट फास्ट मांगते हैं वो यूजुअली ग्रोथ्स की होती है. पेशेंट इज इन एक्यूट ऑब्स्ट्रक्शन एंड वेरियस इलेक्ट्रोलाइट इम्बैलेंसेस. इन दैट केस दे नीड इट. बट व्हाट वी हैव सीन दैट एंडोस्कोपी इज टेकन अ बायोप्सी एट 12 o'clock. We get this biopsy by 1 o'clock, and the second day, the very second day, we can give report by 11 o'clock.
ये छोटी बायोप्सी अलग से चल जाए मॉर्निंग में और बड़ी बायोप्सी चल जाए, रिपोर्ट भले हम 2 दिन बाद करें, मगर दोनों साथ साथ नहीं चलते. ये है हमारा मोटिव. है
So basic motive is to prioritize that biopsies. Smaller biopsy should be given the priority over your that tissue. But that is our local local management. We can this yeah.
वो हम इसलिए चाहते हैं कि नहीं तो क्या है कि वो तो सारी ओवर हो जाती है. हार्डन हो जाती है और वो फिर चलती है।
नहीं, वो जो छोटी बायोप्सीज हैं वो बिल्कुल अलग चलनी चाहिए, एंड उसके लिए एक अपना प्रोटोकॉल भी सेट किया जा सकता है, जैसे आपने बोला कि टाइमिंग कुछ कम करके, बिकॉज बहुत छोटी बायोप्सीज में बहुत ज़्यादा टाइमिंग की जरूरत नहीं है कि हम वही प्रोसीजर 12 घंटे का चलाएं जो हम अदरवाइज यूट्रस में चला रहे हैं। सो देर इज़ नॉट रिक्वायर्ड, क्योंकि फिर वो बायोप्सी ब्रिटल हो जाती है। एक बार आपका जो ब्लॉक है वो माइक्रोटोम से उतरा, आपने वापस को डीसी के लिए बोला तो इट इज़ स्पॉइल्ड, दैट बायोप्सी इज गॉन फॉर एवर।
दूसरा ये होता है इन ए प्राइवेट लैब देयर आर a biopsy going to a medical college, the report is on third day. Biopsy going to a private laboratory, you give the report by 6, you can increase the number of biopsies there. I am talking about monetary, because then people will be more inclined to send the biopsy to you and get the report on the same day rather than wait for 3 days for the medical college for the report to come.
But the problem is our timing is up to 2 o'clock. that is really a big problem. You know, Rajasthan. So yeah, there is no one to report. Patient has to wait because this system needs changes. Sir, but practically Friday was also half day.
For what is the solution which I have done? Start the biopsy in the hospital, which runs 24 hours a day.
Yeah.
In NGH, we are doing 24 hours. So that is open 24 hours. That is open 24 hours. No, 24 hours technicians are available. One and other technician is available. We have trained all the technicians for that.
One doctor is also always available around the clock.
We have trained all the technicians that are posted in the central lab.
And probably we are doing crossing 2 times in a day.
We can do 2 times, 3 times also.
Actually, basically it is the problem of timing of working hours of the institute. We have 8 to 2, so we have a really less time to work. Otherwise, institute which have 9 to 5 working hours, there is really not required to function.
Teaching the student, not reporting. अपना ये है कोई पढ़ा ना तो 2 दिन की जगह 3 दिन की रिपोर्ट कर सकता है। सेम डे तो देना जरूरी
नहीं, लेकिन पेशेंट की बेनिफिट में अगर सेम डे दे सके, जैसे सर ने बोला कि आप शाम तक दे सके, तो दैट कैन बी अ वेरी गुड प्रैक्टिस, बट आई डोंट नो हाउ मच इट इज़ feasible for us.
Because she is in private, she can increase the revenue. For me, it's all right. आप 4 दिन में दो, 5 दिन में दो, मुझे कोई फर्क नहीं पड़ता। मैं तो बाहर बैठ के तमाशा देखने वाला हूँ।
Thank you so much, sir. I'll request our respected chairpersons to felicitate Dr. Kishore Khatri, sir. Now I'll request Dr. Anurag Gupta sir to come upon stage and felicitate our chairpersons.
free papers are actually getting done in Hall B. So we will be getting free in 15-20 minutes, and then the results would be declared of free papers and posters.
Time for small intestinal mucosal biopsy is about 5 to 6 hours. If biopsies are left in formalin for more than 36 hours, especially on weekends, the tissue becomes hard, brittle and difficult to cut. Fixing the biopsies in formalin for a prolonged time also leads to loss of immunoreactivity, and this we have seen these cases. So we have applied some antibody there and 2 times, 3 times repeating, but there is no staining. So this is all because of overfixation. We don't need it. The ideal volume is 25 to 10 to 1 to generate optimum osmotically driven forces, but I think what they are sending biopsies in urine container, the volume is, for practical purpose, volume is good enough for proper fixation. Then how this biopsy should be mounted on a filter paper, face up, shining surface should be face up, then entire your paper mounted paper should be placed in formalin container face down. Transport should be as soon as possible at room temperature, no freezing, no microwave, no heating. The filter paper mounted biopsy fragment should not be separated, and individual mounted biopsy fragment should be wrapped in a bigger piece of filter paper during grossing like an envelope, keeping the mucosal fragments up and kept in a cassette. So we should not remove the biopsy fragments from the filter paper. You put this filter paper as such in a bigger filter paper, that is a usual practice. Less than 4 biopsy fragments should be put in one cassette. If we have more than 4 biopsy fragments or multiple biopsy fragments, we have usual tendency to put in all in one cassette, so that is not desirable. Post trimming, at least 5 step sections should be cut from formalin fixed tissue block, keeping the level 1 cut towards the slide level for identifying the sequence of step sections during light microscopy interpretation. Of all the step sections, the most oriented step section should be marked for future reference. The biopsy should always be accompanied by a properly filled requisition form. Mandatorily, a history of medications, especially olmesartan, is known to cause celiac-like changes. Then non-steroidal anti-inflammatory drugs, angiotensin II receptor blockers, proton pump inhibitors, various chemotherapeutic medications and anti-PD-L1 medications should be mentioned. Post-fixation, identification of mucosal pole is difficult due to change of color of mucosa to tan brown and loss of mucosal shine. In most situations, the muscularis mucosa contracts, that is very important. Muscularis mucosa will be contracted in formalin, leaving the mucosal surface on the convexity of the contracted biopsy fragments. That can help in proper orientation of tissue. Garg et al. Compared the orienting free floating biopsies sent in containers over biopsies mounted on Whatman filter paper and lens papers with and without application of albumin as an adhesive substance during grossing, and found that with the use of lens paper and albumin, the percentage length orientation of the biopsy fragments were best. Whereas those mounted on Whatman filter paper only without any adhesive, they were not that good. Although that is a comparative study, but the worst orientation is with when we put the biopsy freely in the formalin without any mounting. Now, there is one study from veterinary science. What they have done that they used 3 mounting media. One was your filter paper, other was your thin cucumber slice, and third was artificial gel. So the results of artificial gel, biopsies mounted on artificial gel were the best, and worst was the your filter paper. So what they have recommended that if you have cucumber slice on which you have mounted the biopsy, and we have received that we have received that cucumber slice, we should not remove this cucumber slide. That cucumber slide as such should be placed in your cassette, and section should be cut. So it should not be removed. Now thickness for interpretation. Recommended thickness is 4 micron. This is important specifically for the celiac disease, because as we know, for normal intraepithelial lymphocyte count is less than 25 per 100 epithelial cell. If they are 25 to 30 intraepithelial lymphocyte, this is known as borderline intraepithelial lymphocytosis. For Mars grading, we need more than 30. But that will also depend upon the thickness of section. If we have a section of 6 micron, then 25 or 30 figure, that will not be appropriate. In that case, we have to standardize it, and various studies have done. They have recommended that if you are using 6 micron section is the standard as in your lab, then it should be somewhere 35 to 36 intraepithelial lymphocyte per 100 epithelial cells. So better, as we are following the Mars grading, so it will be better to have a section that is 4 micron thickness and use 25 or 30 as your cutoff value. Now, how a oriented biopsy looks like, we can see in figure A, there are villi which are parallelly arranged, and crypts are horizontal. Crypts are also parallelly placed, and they are elongated. In section D, you see crypts are round. The round crypts, we have multiple round crypts, that is not considered as a well-oriented biopsy. How to see villus atrophy, normal villi, and how to take the length of crypts and consider the ratio of villus to crypt ratio. Now we can see here, these are the villi, and these are the crypts. These are muscularis mucosa. Now we can see here that the surface is flattened, no villi are seen, and there is crypts which are elongated. So this can be considered as a oriented biopsy. Now what we need to see here, that is a flat biopsy. We can see here the sort of villus which is almost flat. Then take a shoulder here, and this length and this length should be compared. In Mars grade 3, 3A, where we see villus to crypt ratio 3 to 1 or less, 1 to 1 is almost equal to 3B grade, and less than that, that is crypt is hypertrophy, villi almost flat or ratio less than 3 will be considered as Mars grade 3C. The same image, oriented gastric biopsy should look like this with musculus mucosa as a standard guideline. Oriented colonic biopsies with cigar shaped or test tube in rack position of crypts. Now there are various biopsy trauma during sampling, maybe tissue fragmentation or crushing artifacts, denudation of epithelium. All these things can be seen in a biopsy once we have that section, but still we need to see whether this section is interpretable or not. So that is very important. Now macroscopic description, once we received this biopsy, oriented biopsy in our gross room, then every number of fragments should be written. 3-dimensional measurement of every biopsy fragment should be mentioned. Individual biopsies, the endoscopic biopsies may be processed and embedded either as individual samples or more usually combined into one multi-cassette. Multi-cassette, we are not using multi-cassette. The use of multi-cassette is not only cost effective, but it also speeds up reporting time by the consultant. This is the picture of multi-cassette, basically a single cassette with multiple wells. So biopsies can be placed in this wells, but we need to take care that this cassette itself is not lost. That is the usual practice. Sometimes we lose this, we lose these cassettes और आपका टेक्नीशियन बोलता है कि सर कैसेट ही नहीं मिल रही, ब्लॉग मिल ही नहीं रहा. This is the summarization how biopsy fragments should be mounted on filter paper, then how to put it in formalin, and how the sections should be cut on slides. These are example of these biopsies mounted on various medias. You can see in this picture, these all are the vegetable cells of cucumber slice. This is the picture of microscopic photograph of biopsy which were sent directly in formalin without any mounting media. So you can see the changes, difference in the quality of sections. Again, you can see the same biopsy which were sent in mounted on cucumber slice with these vegetable cells. We can see the length of this biopsy, and we can see the length of your biopsy. The epithelium is here and here, both sides. That is not normal. So this is unoriented biopsy. If you consider this length of the villi, there is villus atrophy with the cryptal areas, lamina is widened. It should not be interpreted for celiac disease. Thank you.
Hello.
Thank you very much, sir.
Thank you. Thank you, Dr. Kishore, for nice presentation and considering the basic and practical problems which we are facing in routine to day-to-day practice. And I think the problem begins from the operation theaters only. So we should reach them also. And it was an excellent presentation and enlightening the residents and faculties too. Thank you very much.
I would like to congratulate you. Really made a very basic and very good presentation, which is very, very important to start with.
Thank you.
Any questions from audience?
Microwave processing we are not using, so I don't have any experience of microwave processing, but what they recommend that should not be, because these tissues are so small that it doesn't take a lot of time to actually fix, to get fixed. So I think by the time tissue is put in formalin and the patient comes to us, and at the time of grossing, 2 to 3 hours it usually takes, and an ideal recommendation time is 5 to 6 hours. The time lapses, and I think we don't have any experience.
माइक्रोवेव में तो ऐसे भी टाइम कम ही लेते हैं. रिसेंट एनालिसिस में भी आया हुआ है, माइक्रोवेव इज प्रिफर्ड. स्मॉल बायोप्सी में माइक्रोवेव प्रोसीजर इज प्रिफर्ड.
But sir, various studies actually, there are studies favoring these microwave processing of the tissue, but what various studies have also recommended at the same time, that is the opposite side, that there should not be heating of this tissue. So, yeah.
We used to do this microwave processing way back in 1997, and Dr. Balraman Nair, coming from Chennai, from Trivandrum, he suggested that endoscopic biopsies they receive by 12 o'clock. Half an hour for fixation in formalin, buffered formalin in microwave, and then 4 changes of alcohol in microwave, 5 minutes each, 2 changes in chloroform in microwave, go for embedding and sectioning. So the tissue received by 5 o'clock daytime, by 6 o'clock the reports are out.
Yes, sir, but in that case, we have to be very sure that these biopsies are actually mounted on filter paper. Otherwise, any sort of external temperature variation, that will cause artifactual changes.
For that also he suggested a solution that in the microwave, the cassettes are put in a smaller beaker, and because the heat is generated. So in the same microwave, put a 2-liter beaker filled with water, so that most of the heat is absorbed by that 2-liter water, and the tissue will not get heated. So that heat artifacts can be avoided. We used this technique for almost 3 years, but then we had some problem with the microwave itself, and we didn't buy a new one, so we left it. But while we were doing for 3 years, we were giving report earlier, and the reports were satisfactory.
Actually, sir, this your experience of putting that water to absorb the excess heat should be published. Actually, this is no, it needs that is your local your local issue which was solved by you. But in literature, actually, I have not come across this type of thing. I am not aware of this, but yes, your procedure should be standardized and should be published to make other people's benefited.
स्मॉल बायोप्सी के अंदर तो आधा आधा घंटा एक एक घंटे करके सेम डे ही रिपोर्टिंग का लिखा हुआ है. मॉर्निंग में आप डालेंगे सुबह 9 बजे, इट विल बी फिक्स एट 1 o'clock विदिन 4 or 6 hours. ये भी लिखा हुआ है, WHO में लिखा हुआ है ऐसा.
हाँ सर, वो लिखा हुआ है, लेकिन जो
छोटी बायोप्सी के लिए
ये सर, लेकिन जो प्रोसेसिंग टिश्यू है ना, जो प्रोसेसिंग का जो प्रोसीजर है उसको मॉडिफाई किया जा सकता है फॉर स्मॉल बायोप्सी एंड दिस इज अ स्टैंडर्ड. यस,
मैं उसको ट्राई कर रहा हूँ कि बायोप्सी छोटी लेके देखते हैं उसके रिजल्ट कैसे आते हैं. वो पोस्टमार्टम में कर रहा हूँ पहले.
ओके,
अगर पोस्टमार्टम में अगर रिजल्ट अच्छे आते हैं तो वी कैन रन द स्मॉल बायोप्सी इन द मॉर्निंग आवर्स डे टाइम. उसके बाद में जो आफ्टरनून में बड़ी वाली चल जाएगी. सर नहीं, सर दूसरे सारे उन्होंने बताया था मेरे को ऐसे करो आप राइट. पहले पोस्टमार्टम टिश्यू में वी कैन टेक अगेन छोटा छोटा लेके बैठा. सर भी तेरे माइक्रोवेव कर लीजिए, ये भी करें, थोड़ी चीजें क्या.
Sir, processing of biopsies in patients who have a growth, it is very helpful in letting out the report by evening, where a growth is suspected, and we had done this with, I had the opportunity to work with sir, and we did report it by the evening. It is just like a frozen section, we give the report the same day. If we are giving a report of a malignancy same day, it helps the patient. Yeah, it is better than frozen section, of course, because there are no artifacts.
24 hours is sufficient for giving the report at the earliest possible.
वो ये इसलिए है that all this
With all these processes, we can give report in 24
report
hours.
can be given in 24 hours, but we are working in an institute where after 6 hours lab is closed.
You can change your institute time also. It depends upon you only.
एक्चुअली जो गेस्ट्रोएंटरोलॉजिस्ट जो रिपोर्ट फास्ट मांगते हैं वो यूजुअली ग्रोथ्स की होती है. पेशेंट इज इन एक्यूट ऑब्स्ट्रक्शन एंड वेरियस इलेक्ट्रोलाइट इम्बैलेंसेस. इन दैट केस दे नीड इट. बट व्हाट वी हैव सीन दैट एंडोस्कोपी इज टेकन अ बायोप्सी एट 12 o'clock. We get this biopsy by 1 o'clock, and the second day, the very second day, we can give report by 11 o'clock.
ये छोटी बायोप्सी अलग से चल जाए मॉर्निंग में और बड़ी बायोप्सी चल जाए. रिपोर्ट भले हम 2 दिन बाद करें, मगर दोनों साथ साथ नहीं चलते. ये है हमारा मोटिव है.
So basic motive is to prioritize that biopsies. Smaller biopsy should be given the priority over your that tissue. But that is our local management. We can this yeah.
वो हम इसलिए चाहते हैं कि नहीं तो क्या है कि वो तो सारी ओवर हो जाती है, हार्डन हो जाती है और वो फिर चलती है.
नहीं, वो जो छोटी बायोप्सीज हैं वो बिल्कुल अलग चलनी चाहिए. एंड उसके लिए एक अपना प्रोटोकॉल भी सेट किया जा सकता है, जैसे आपने बोला कि टाइमिंग कुछ कम करके. बिकॉज बहुत छोटी बायोप्सी में बहुत ज़्यादा टाइमिंग की जरूरत नहीं है कि हम वही प्रोसीजर 12 घंटे का चलाएं जो हम अदरवाइज यूट्रस में चला रहे हैं. सो देयर इज़ नॉट रिक्वायर्ड, क्योंकि फिर वो बायोप्सी ब्रिटल हो जाती है. एक बार आपका जो ब्लॉक है वो माइक्रोटोम से उतरा, आपने वापस को डीसी के लिए बोला तो इट इज़ स्पॉइल्ड. दैट बायोप्सी इज गॉन फॉर एवर.
दूसरा ये होता था इन ए प्राइवेट लैब देयर आर a biopsy going to a medical college, the report is on 3rd day. Biopsy going to a private laboratory, you give the report by 6, you can increase the number of biopsies there. I am talking about monitoring, because then people will be more inclined to send the biopsy to you and get the report on the same day rather than wait for 3 days for the medical college for the report to come.
But the problem is our timing is up to 2 o'clock. that is really a big problem. Rajasthan. So yeah, there is no one to report. Patient has to wait because this system needs changes. Sir, but practically Friday was also half day.
For there is solution which I have done. Start the biopsies in the hospital, which runs 24 hours a day. In NGH, we are doing 24 hours. So that is open 24 hours. That is open 24 hours. But then technicians there for the no, 24 hours technicians are for that. We have trained all the technicians that are posted in the central lab.
And probably we are doing crossing 2 times in a day.
We can do 2 times, 3 times also.
Actually, this is basically it is the problem of timing of working hours of the institute. We have 8 to 2, so we have a really less time to work. Otherwise, institute which have 9 to 5 working hours, there is really not required to function.
Teaching the student, not reporting. अपना ये है कोई पढ़ा था तो 2 दिन की जगह 3 दिन की रिपोर्ट कर सकता है. सेम डे तो देना जरूरी नहीं.
नहीं, लेकिन पेशेंट की बेनिफिट में अगर सेम डे दे सके, जैसे सर ने बोला कि आप शाम तक दे सके, तो that can be a very good practice, but I don't know how much it is feasible for us.
Because she's in private, she can increase the revenue. For me, it's all right. आप 4 दिन में दो, 5 दिन में दो, मुझे कोई फर्क नहीं पड़ता. मैं तो बाहर बैठ के तमाशा देखने वाला हूँ.
Thank you so much, sir. I'll request our respected chairpersons to felicitate Dr. Kishore Khatri, sir. Now I'll request Dr. Anurag Gupta sir to come upon stage and felicitate our chairpersons.
Free papers are actually getting done in Hall B. So we will be getting free in 15-20 minutes, and then the results would be declared of free papers and posters. सर आपको वहाँ खड़े
क्या नवाज जाऊँ
We now declare the results of our papers and posters presentation. First we'll go for the posters. The third prize, Dr. Anna Rao Patil from Dr. SN Medical College, posters. And it is also shared by Dr. Sikandar Purohit. Dr. Sikandar Purohit. Third prize is shared by two people. Dr. Sikandar Purohit, Dr. Anna Rao Patil. पेपर सर के हाथ वाला Second prize is also shared by two people, Dr. Prachi Jain from SN Medical College, and Dr. Rushali Gadre from Indore Medical College. Congratulations. Dr. Rushali. And first prize in the poster presentation is Dr. Sangeeta Pradhan from AIIMS Medical College. Next we come to the paper presentation. The third prize goes to Dr. Charu Rathore from Dr. SN Medical College. Dr. Charu Rathore. She is from Department of Biochemistry. Second prize, Dr. Venika Yadav from Dr. SN Medical College. And first prize, Dr. Saloni Sangal. Dr. Saloni Sangal from Kasturba Medical College. Anyone else from Kasturba Medical College? No? Okay, thank you very much.
Okay, ladies and gentlemen, now we have come to almost the completion of the State Conference of Rajasthan chapter of IIPM. Now, it was a really very good experience with all of you coming to the conference. For me, it was a small challenge because I knew that I am going to have a very good team to help me out of this endeavor. I'm sure, as I got the feedback from everybody, the conference has been good and has been enjoyed by most of the people. Always there are some criticism, but if I calculate, the criticism was about 5% and 95% was an appreciation. And appreciation was not for me, but for all the delegates, the way they have behaved. Now, the conference would not have been successful without the help of people from SN Medical College, especially Dr. Madhu Gupta, Dr. Anand Raj, Dr. Yogi Raj, Dr. Khatri, Dr. Omveer, Dr. Kanchan Rathod, Vipul Gurjar, of course. He's a very, very good person, and he's a key person who has helped me a lot with his extensive knowledge of computer, because for me, making a spreadsheet and analyzing it, sending mass emails, I don't know anything about it, and he made it possible very easily. For him it was a not big job, but for me it was a very, very big job. I am also thankful to all the commercial establishments who have helped financially, and also they have increased the attraction and academic interaction with the delegates, showing their equipments, showing their latest techniques and others. I thank everybody who has come to the conference, who have morally supported me, physically supported me. I'm sure you should have relished the occasion, and it will be a memorable. It will remain in your memory for at least some days. Now, we also know that Jaipur has opted for the next RAJPATHCON to be held somewhere end of September next year. We hope we'll all meet there again. All the best. Thank you.